of, but we cannot be satisfied. Today, we cannot accept every patient in our facilities that needs the care that only we can provide. Today, we have more of our own people, our UK employees, those in medically underserved areas and in the region who are asking for expanded access to our health services. Today, we need to do more to retain the talent we have and recruit even more to join them to meet the growing health needs of our Commonwealth. As much as we have done together, fueled by the leadership of this health system and the thousands of healers and providers who support them, there is still much more to do. We must grow as an academic health system within a university enterprise that is singularly focused on advancing Kentucky, its health, its economy, and its education. Over the next few hours, we will hear from our leadership team that has devoted the last few months to collaboratively re-examining UK Healthcare's existing strategic plan with fresh eyes. The goal was not to rewrite or overhaul our forward-looking vision for addressing the health needs of the state. Rather, we want to refresh, reframe, and recalibrate that vision. During a time of transition and dynamic change throughout the healthcare landscape, it is our responsibility to ensure we are meeting the growing needs of our state. We will remain focused on the mission we established more than 15 years ago, that no matter who you are or where you live in Kentucky, there is a place close to home to meet your advanced care needs. This is who we are, this is what we do. But that also means recognizing and responding to the growing primary and ambulatory care needs of our people and those who don't have access to the care we provide. This afternoon, to that end, we will address several challenging questions and responsive strategies together. How do we enhance our capacity for advanced subspecialty care to meet growing patient needs? How do we ensure we have the talent to do so? How do we take care of people and our community, which is this Commonwealth? How do we grow thoughtfully and strategically as an academic health system? How do we align as that system within a growing university enterprise whose vision is to advance this state in everything that we do? And of course, how do we make and manage a long-term budget plan to fuel our growth, maintain our presence, and appropriately take care of our people so that we can meet this moment now and going forward? As a board and healthcare committee, we have the privilege and the responsibility to lead and support an essential health system within a vibrant and growing university as it serves a state that needs what we do more than ever. I look forward to our time this afternoon and yield the floor to President Capilouto.
Thank you, Chair Brockman, and I too extend my welcome to our community members, our new ones, and all who could be here today. And in advance of the presentations you're going to hear, the numerous individuals and those who work with them, alongside them, that made possible, I think, the compelling information that you're going to see this afternoon. As someone who resides on this campus, and as I listen to Chair Brockman, I'm reminded almost every day of the gratitude and reverence we should have for those who came before us. In 1958, this board was wrestling with an audacious and ambitious topic: how to develop a medical center that would serve the entire state. And there was fierce opposition to this, fierce opposition. And there was what almost seemed insurmountable task of determining how we would fund it. And I've been around long enough that I knew some of those early leaders, and at a college that recognized one of those founding deans, I talked to the family members who recalled how their father sacrificed personal health, but family opportunities to make sure that college opened. When the budget was short, this dean was instructed by the governor, well, just delay opening the college. The problem is the dean had already admitted the class, and he did everything he could to make sure those doors open. So there's all of these heroic chapters that bring us here today. And I thank Chipper Griffin, who says this is a report that remains in the dean's office in the College of Medicine. He shared it with me last year. What did this report say? The purposes of this medical center, this is in the late 50s, were outlined in plain, straightforward, and direct language. To train more doctors and health personnel to serve Kentucky, to facilitate research, to provide medical care to the indigent, to provide a base for a medical center which will serve the entire state. The center, the report continued, will be oriented toward the special and unique problems of Kentucky and will house an integrated array of facilities that will have affiliations with hospitals as part of a mission to achieve the highest quality programs. So that was 1958. And it could have been written in 2023, but not as a lament about what hasn't been accomplished and what remains to be done, but as a testament to the enduring and compelling vision, so powerful that it continues to fuel our ambitions and drive our every dreams today. Chair Brockman outlined several points of progress that our healthcare system has made in the last 15 years. From rankings and measures of quality to tangible results of treating and healing more patients in every corner of our Commonwealth. Led by this board and sparked by the creativity and commitment of so many talented people throughout this enterprise, you have built a nationally recognized academic health, not center, but now system today. And when we needed them, and we did need them, our elected officials and policymakers stood tall with us. So we are poised and positioned as never before to do even more for the state we are called to advance through care and compassion. And that, in essence, is what we are here to learn more about and discuss more deeply this afternoon. How we convert the promise of continued progress into the treatment and increasingly the prevention of more disease in our state. The vision and mission are really the same as they were in 1958, to be a beacon of hope and center of healing throughout Kentucky. More than 15 years ago, that vision was crystallized around the idea of ensuring, as Dr. Brockman said, that no Kentuckian would have to venture far from home to receive the best in advance subspecialty care. We refreshed and re-examined our planning over the years, but our focus has really remained fixed. We are compelled by the needs of our state to continue to build and sustain our presence as Kentucky's premier center for advanced care. But we all know we're at an inflection point. As you'll learn more about today, the landscape for healthcare is undergoing dramatic change. The financial pressures for hospitals, large and small, continue to increase. We face these challenges of recruiting and retaining the best workforce, the immensely talented physicians, nurses, technicians, and others who support the healing we make possible here. More people, both within the UK community and those who simply cannot access the care we provide for many reasons, have primary and ambulatory treatment needs that should be filled closer to home. We are now this sprawling academic health system within a growing and thriving university enterprise, something those on whose shoulders we stand could never have envisioned more than six decades ago. It's remarkable to me. We have built, not for ourselves or for the names on the buildings or for acclaim, we built for Kentucky. We built for this state, for its health and its future. And we must continue to do what is possible to grow to meet the growing needs of our states. Doing so, though, will require a clear-eyed, pragmatic approach to long-range budgeting and planning. The things we talk about today will not occur overnight, but the planning must be set forth. There's a saying you often hear in healthcare. I've heard it for 50 years. No margin, no mission. And the reason it's been around so long and it's so often used is it's true. To make real our dreams for a healthier state, we must make real a sustainable budget that supports our mission. What you will hear and learn more about today is the result of purposeful and collaborative planning throughout thoughtful strategy and a continued commitment to dreaming about what is possible for the health of a people and a state we're all privileged to serve. We face big challenges. We faced them before in expanding our reach as an academic health system that plays an integral role in our institution's mission to advance Kentucky. But we also have incredible opportunities to do and be more, as Dr. Brockman said, for Kentucky. So I hope that this afternoon leaves you excited, challenged about what we face and what we can do and only do together. Mr. Chairman.
Thank you, Mr. President. At this point, we'll begin the business aspect of this meeting. I'll yield the floor to Acting Co-Executive Vice President of Healthcare, Provost Robert DiPaolo, and Executive Vice President of Finance Administration, Eric Monday, for opening comments. We would ask that if there are any questions, you please hold the questions until the end of each of these themes that we're going to go through, and we'll have plenty of time for questions at the end of each section. So thank you.
Thank you, Chair Brockman and President Capilouto. I'm going to show you a bit of an overview of the agenda for today, and then Eric and I will walk through the rest of this in terms of opening up and an overview of what you'll hear throughout the whole afternoon as well. I think you can see very clearly that Chair Brockman and President Capilouto have framed well the essence and essentiality of UK healthcare to advance the health and well-being of our state and our Kentuckians. We know, however, that there's a dynamic and changing landscape, and you can see on the agenda, at least the first agenda item, is an overview of that national landscape by our consultants with Kaufman Hall. And Jason Sussman is here to present that. It'll give us a framework so you can see all the components that we're going to be talking about this afternoon and how they fit within that national landscape. Then, along with leadership throughout the healthcare enterprise, we'll discuss with you the three themes that you heard clearly elucidated by Chair Brockman. We've done a qualitative and quantitative assessment and research. Eric and I, along with the whole leadership team at UK Healthcare. What you're going to hear a lot is the term strategic refresh throughout this retreat. We want to be clear that this refresh is not a strategic change in direction. Although our strategy has evolved, we remain committed to our 2025 strategy that includes an emphasis on quality, health equity, and value, as you all know. You can see the three themes there listed, 1, 2, and 3. And when you look at theme 1, it's an overview and a deep dive into that special responsibility we have to provide the best advanced subspecialty care while creating greater access, saying yes more to those in need that need to come to our institution here. I think you know that in the past, we were even #1 in transfers to this institution. We want to keep focusing on that. And when we talk about subspecialty care, we talk about the wide range of opportunities here, including transplant as one example. Obviously, we're going to need to expand our existing Chandler footprint and within the campus, and you'll hear more about how we're doing that in a little while. We want to, as you heard, make sure no Kentuckian needs to leave the state for their care, for any care. This is a collaborative approach as well with our partners. You heard that as well. In theme 2, you'll hear more about taking care of our community, people, and our talent. We're going to pay attention to our talent, our workforce, how we improve that over time, and pay attention to infrastructure, how we'll enhance ambulatory opportunities, especially in primary care, for our own people and our community. And you'll hear about that as well in terms of what we're doing in terms of ambulatory care facilities. And then the third aim for discussion centers around, as you just heard, what it means to be an academic health system for Kentucky. This is what makes us distinct, as well as the advanced subspecialty care. It gives me a special passion as well, having the opportunity to be dean on one end of the campus and provost on this end, or the campus as a whole, seeing what we can leverage and continue to leverage in terms of strengths in research and education to enhance what we do in clinical care every single day. Research drives clinical care impact. We think about that in terms of bench to bedside work, clinical research, and we'll talk today about ways that we're going to enhance what we do there. Lisa Cassis is in the back, our Vice President for Research, and she actually tells us that we continue to grow in terms of research funding and opportunities, and I think we're at about $450 million in awards this past year. Education as well drives the expertise we have locally in our health system and in our community as well. It is also true, as President Capilouto remarked a moment ago, that no margin means no mission. We have developed pragmatically, realistically, and with a clear focus, a 5-year budget plan that puts numbers to dreams, dollars and figures to ambitions. We will review those numbers in combination with our performance so far this year to detail how we plan to finance the healthcare goals we have for the state. And finally, we hope after a deep discussion and review, we'll be in a position with you to summarize where we are and receive your consideration for an endorsement for where we're going in our collective efforts to advance the health of Kentucky. There are also several finance resolutions that we're going to present to you regarding the planning, design, and continued build-out of our infrastructure needs necessary to address the capacity needs and growing issues we face. I'm going to stop there and turn it over to Eric, who's going to tell you how we got to this particular point, and then we'll continue on with the retreat. Eric?
Thank you, Bob. Chair Brockman, members of the Healthcare Committee, members of our board, Chair Vance, Mr. President, it's a pleasure to be with you and to present all of the themes in this retreat today. As Bob said, where we started, where we began this process back in January is to fully understand and to be framed by our amazing evolution of our path. And so today is not in lieu of, it is in addition to. So framed by this slide of looking at the last 20 years of growth, of opportunity, of how do we advance the healthcare needs and solve those needs for Kentucky. So we've started here, and then we went to this next slide and looked at exactly what was understood when we think about the strategy, when we think about our path. And so these are slides that we distributed to a team of leaders, many of those leaders are here with us today in this room, and we appreciate their attendance and participation. Bob and I are up here to explain the story, but this story is not about Bob or Eric. It's about the story of thousands of our employees that are allowing us to achieve the outcomes and improve the healthcare of Kentucky. So when we think about this strategy and we think about 2005 to 2015 to 2020, it has evolved. We started with that mission, that focused area that you heard the president talk about, you heard Bob talk about. A Kentuckian does not have to leave Kentucky, no matter they're ill or challenged. And then where we expanded that is we expanded that and achieved that about relationships. And we built these amazing partnerships with hospitals across Kentucky. Tens of thousands of transfers of saying yes more than saying no. And we're going to talk about how we're going to get back to that point later today. And then we focused and we evolved to think about those ambulatory needs. How do we get closer to our patients? And when we're talking about our patients, we're also talking about our people. We have over 30,000 lives covered on just our HMO and PPO health plan at the institution. And so we got to remember that base and how we take care of that base. And we move closer to where they are. And we're going to talk about that today. We're going to share some strategy around that. And then if we think about the last 5 years, I think the crowning achievement of the implementation of this strategy, of the evolution since 2005, is our partnerships with King's Daughters. We had our quarterly board meeting with King's Daughters yesterday in Ashland. Fantastic meeting. Sarah Marks, our newly appointed CEO permanent, is with us today. Audit McFan, the CFO with expanded responsibilities, is here today. And that partnership is deep and is an evolution of building a system to improve the healthcare of the entire Commonwealth. And so what we did, and what Bob and I looked at those first two slides, we circulated that, had over 10 meetings with the various leaders in this room and outside this room, including our physicians, including our administrative staff, including our staff members, is we posed these questions. This is what we saw as the strategy. This is what we came into the conversation thinking as we saw it, as we understood it. Are we going to continue to be advanced subspecialty care? Is that what Kentucky needs? Is that what we're good at? When we think about our people, it's not about just taking care of our workforce, but we got to expand that workforce. And how do we think about the talent and growing the talent and expanding those 7 health-related colleges, thinking about partners, thinking about other acquisitions, thinking about strategies to look at that talent that's needed. And you're going to hear details of what we see just in the next 5 years, and some amazing numbers of additional employees that we need here at the university. And then lastly, that AMC and that distinctive functional effort of bringing all those 4 missions together. And so what we heard and why we got to the point we are today is represented on this word cloud. We charted and graphed what we heard from our team, from the people. Size matters on this, as we heard that more. Access, access, access. Saying yes more than saying no. Being more responsive to our partners. These are hospitals where these patients have no other place to go. How do we take advantage of the distinctive nature of being in that University of Kentucky environment? Having 7 health-related colleges. How do we deepen those partnerships? How do we deepen the partnership in our research mission with Dr. Cassis and her team? At the same time, there's a number of things that we have to do better, and we have to continue to attack and focus in on. Our length of stay. Right? How do we think about a post-acute strategy? You'll hear about those things today. But you see talent and infrastructure, you see workforce, because what we're talking about today, of course, is this refresh of strategy. How we implement that is through people and through projects, through talent and infrastructure. And we'll talk about those, of course, when we get to those FCRs and the University Healthcare Committee resolution. You'll also see some very defining needs of the Commonwealth: pediatrics, behavioral health, women's health, and some actions that we're taking. We're seeking your approval to take immediately to attack those in a positive way. So in the end, the three themes of today are totally built on what we heard, where we want to go, where the team wants to go. Advance of specialty care, that is what we're good at. That's the faculty that we have recruited. The physicians are at the bedside and the support team to support those activities. Number two is we got to think about our workforce, and we got to think about taking care of our people and their healthcare needs differently. And that means getting closer to where they are and where they live. And third, you're going to hear a lot about that distinctive component. We aren't a community hospital, folks. No harm, no foul, nothing wrong. We are an academic health system. We're taking that research, that opportunity, and bringing it to the bedside. And how do we continue to do that and expand beyond that? So that's what we're going to do today. There is not a day that I have been more excited for a Board of Trustees meeting than today, because it is going to be a discussion and a path towards progress to advance Kentucky, and that is our North Star. So I'm going to transition now and invite Jason Sussman to come up. Let me tell you just a little bit about him. A number of you have met him before. Jason has been with us for a few decades. He works and he's a managing director at Kaufman Hall, a major consulting firm. They don't just consult in healthcare, folks. They're consulting in higher education, and they're just not a financial consultant, they're a strategy consultant. So a lot of what we have achieved, Jason's got some fingerprints on it. So he's going to come up here and he's going to also talk beyond Kentucky and understand that national healthcare landscape. We talked a lot about internal. What are those external factors? Jason?
Thank you, Eric. And it is a pleasure. It's been probably 5 years or more since I've had the opportunity to talk to this group, and I really do appreciate the opportunity to be back here. And as Eric said, this is a somewhat of an inflection point and an important point in time for UK healthcare and for the university. And the work that's been done and the perspectives that you'll see, I think will really help you in terms of moving that strategy forward. And hopefully I can add just a bit of perspective to that conversation. What I'd like to do is spend just a few minutes giving you a broad picture nationwide of the implications of changes in healthcare for hospitals of all kinds. And then we'll focus that in comparing UK healthcare performance to other academic medical centers, to the region and the like, and what the implications of that may be as you continue your deliberations today. First, we'll look at operational issues, and then we'll broaden out into more strategic issues. So just moving right ahead, let me just start by saying 2022 was probably purely from a financial perspective, the most difficult year for hospitals and healthcare providers nationwide since, well, in recent history. Even the time of 2008, 2009, when we had the capital markets crisis, the issues that are facing the healthcare industry weren't as pernicious, if I can use that word, as they were in 2002. You can see that on this graph right here. This is the month-to-month median operating margins for healthcare providers across the country. This is about 1,000 hospitals around the country. And it was a combination of, we had the Omicron surge, we have inflation, cost inflation, we have revenues that aren't keeping up with that cost inflation. And you can see for the first part of the year, the operating losses were significant. They've mitigated somewhat in the second half of the year, and you can see that in the beginning parts of 2023, profitability is still elusive for more It's 53% of hospitals within this database are showing a negative operating margin. And that is just the continuation of high inflation, of labor scarcity, of retention of labor. It's also non-labor costs, supply chain issues, and all of those things combined with the fact that nationally speaking, volumes, which dropped significantly in 2020, 2021, have come back, but have not come back to the levels we saw prior to the pandemic. Especially emergency room, which is a front door in a lot of cases to hospitals, and on the outpatient side. And so you can see here, 53% of hospitals had negative margins in 22 and continue to have negative margins in the early parts of 23. But what does that mean relative to UK healthcare? Well, if we look at UK healthcare's profitability relative to three medians here, let's see if nope, that's not the right button, sorry. Here we go. So here's UK healthcare. This is operating margin and operating EBITDA margin, which is operating margin before the effect of depreciation and interest, for those who don't know. You see that UK operating margin 11.4, 13.9, nationally 0.3% and 4.9. This is the southern region, which is all of the Southeast plus Kentucky. It's a little bulge out in the region. That's 270 hospitals in that region and 31 academic medical centers. And you can see that with the inclusion of revenue from all sources, UK healthcare is clearly outperforming the medians of any comparison. Now you'll note in the parentheses that we say inclusive of directed payments. It might not be a term you're familiar with, but directed payments is what we would consider a supplemental payment program. It's based in the Medicaid program, but it's a supplemental payment program that provides additional funding for access to care, and uniquely to Kentucky, the directed payment program for UK healthcare and the University of Louisville provides that payment level for academic provision of academics and the cost of providing that teaching and other activities related to a university medical center. And so this is the full picture. What I want to point out to you is that that directed payment is significant. And we know that because if we pull that out, here's where UK healthcare falls without those directed payments. So the fact of the matter is that at this point in time and later on when you see the year-to-date performance, you'll see that UK healthcare is profitable, and it is. But a big portion of that profitability is coming through this supplemental payment program. And what that means, and you'll see this as we dig deeper here, that there is opportunity and needs to be a continued focus from a management perspective to take the full benefit of that additional payment by managing and controlling costs to the farthest extent possible. So when we look here, this is revenue. NPSR is net patient service revenue. Sorry for the acronyms. But on a per unit basis, you can see that UK healthcare's revenue is well above the medians for all three of those groupings that I described before. That's a great thing. Problem is when we look at expenses, same message. So the point being that if you have this opportunity where your revenue is strong because of the mix of care you're providing, the different kinds of services, specialty pharmacy, all those types of things, there is a real opportunity if you can begin to manage this number downward in an effective and appropriate way to further generate capacity to support all of the strategies you're going to hear about today. So from a national perspective, the list of things that folks are looking at is up here, right? We have labor costs, number one issue. In every survey, in every conversation you have, with hospital CEOs, with operators. Labor is point number one. Access to labor and cost of labor. For 53% of the hospitals, operating losses are an issue. Not an issue here, but the ability to enhance the performance is always an issue. The other things, because of the strength of the profitability, have not shown up here, which is wonderful. But understand that as we look across the country, these issues about liquidity, about meeting debt service payments and so forth, are real issues for organizations nationwide. So from the perspective of this financial morass that we're in nationally, and the positive position UK healthcare is in regionally, it just puts the onus, if you will, on management to make operations as efficient and effective as possible, to take advantage of the benefits that you have, and to plow those profits right back into providing better care and more broadened care and access for the communities in Kentucky. So that's, if you will, the internal look. And what it tells you is that there are steps to take. And some of these, and you'll hear about them, are in process. But the question is, how do we create and achieve and implement all the strategies to be discussed and maintain and enhance the sustainability of the system? And it's done, if you look at the bottom of the page here, by first of all, looking internally and implementing short-term operating initiatives to enhance the profitability, to enhance operations, to enhance quality, to enhance access. And then understanding what that improvement does, create and identify and implement a strategy that over the long run will achieve the objectives that the organization is looking to achieve. So that is, as I said, the internal look. If we look externally, we see some really interesting patterns. Now, I'm sure most of you are aware of the trend that's been occurring for at least a decade, probably more so, of movement of care from the inpatient setting to the outpatient setting. Eric and Bob both talked about enhancing ambulatory access. That's in response to that trend. That trend continues, and it will continue with technology, with new types of care, et cetera, et cetera. But there's another aspect of evolution happening in the marketplace that you also need to be aware of. And that is that the delivery of care, even on the outpatient basis, is moving away from facility-based care to meeting the consumer where the consumer wants to be met. Okay? When we now talk to consumers about accessing healthcare, they're talking about it in terms of Amazon. I want to be able to click and get what I want today. And so you see more and more a movement to care in the home, to virtual care, at the workplace, where it's convenient for the consumer. And so it's a dilemma for an organization like UK Healthcare, because you have to say to yourself, we're providing advanced subspecialty and subspecialty care. How do we do that at home? But you're not only providing that care, and in enhancing access, as Eric talked about, are there opportunities on the right side of this chart for UK Healthcare to participate, to create access through more innovative means and perhaps less facility-based and less capital-based means? Something to think about as the strategy continues to evolve, because this is where the market is moving. And we know that because we're seeing untold numbers of startups that are tapping into that movement in the marketplace. And what you see here is, on the far left side, you see the hospital, inpatient care. I will tell you that not a single one of these new entrance into the marketplace wants anything at all to do with inpatient care. Feel safe that that's yours forever, okay? Where they're interested is on the other end of the scale. And so as we move left to right, we move away from inpatient, we move to primary care, facility-based primary care, other ambulatory care, all the way to the right to home and virtual care. And I like this chart because what it does is it gives you a sense for the types of companies that are tapping into this. Notice to the far right, we have a couple of small companies you may have heard of, Walmart, CVS Health, right? Highly capitalized. In terms of revenues, UK healthcare, the university pales in comparison. They can put significant dollars of investment into this. We have companies at the far right. There's one there called Luna, which provides, for example, outpatient physical therapy in the home. It's a combination of Uber and physical therapy to make sure that you have a therapist within 30 minutes of your home, and you'll go through the entire care provision. And they have perfected it in a way that looking at it from a broad-based academic medical center, you might not be able to perfect that portion of the care continuum to patients in your community. And then you have everything in between. Soulless mammography, that's all they do. They create centers to provide mammography. I mean, down to the point where they're picking colors based on the psychology for women who come for mammographies, that they'll be comfortable, they won't be pressured or whatever. I don't even understand all this psychology, but pages and pages of research done to make sure that the experience is the best that's possible. And so we have to look at these strategic entrants into the market and say, yes, they're competition, but there also is opportunity related to those entrants. And what I mean by that is that we need to move and need to start thinking about the things that we've said and the theories that we've posited in the past. Number one, either we do it best or we can do it best. Slightly a bit of semantics, but important. And secondarily, we have to do everything. We have to be everything and own everything and provide that to all people all the time. And I think what we're seeing around the country and what we see in organizations that are being innovative and successful is starting to challenge those two theories. And they're doing it by looking at the potential of partnering to accomplish goals that maybe you don't do better than somebody else, or maybe someone can do better than you because they're more focused. And so you have options. You have a range of options. And this is really where the discussions today become important and should color your thinking. At the far left side, you have taking what you have as an independent organization and using that to drive your strategic plan. Maybe everything in the strategy can be done simply in this context. And as for example, the addition of King's Daughters adds another capability to the system. Maybe that's enough. But then you need to take the next step and start to look and say, of all the services we provide in all the locations we provide them, is it the optimal portfolio to make sure that we have a sustainable organization and that we are in fact meeting the needs of all Kentuckians? And then, having understood where the pluses and minuses are in the portfolio, are there potential partnerships that we could enter into to take some of those minuses and make them positives and make the positives even more positives? Some of those partnerships will be of I'll call them the traditional type. But then we also need to look and say, are there alternative types of partnerships that we can enter into where someone else is providing care on our behalf, or supporting our operations on our behalf in a different way that can make us more effective and efficient and allow UK healthcare to focus in on what it does best in terms of specialty and subspecialty care. And so as you think about the various initiatives and you think about the strategies, we have this chart that we use to think about partnerships and alternatives. And you can see at the far left, these are initiatives and partnerships which would have a low degree of integration. And on the far right, there's a high degree of integration. The King's Daughters transaction, pardon me for using that word, falls to the far right. You're highly integrated now that the member substitution has occurred. But are there opportunities on the left-hand side to really enhance the operations and the care that's provided and the teaching and research that's done at UK through the means of others' capital, perhaps, others' expertise, and collaborative use of capital and expertise to accomplish a better outcome? So that's the challenge as you go forward. And that is consistent with what we're seeing in terms of the evolution of the healthcare marketplace. Do I want to take questions now or wait to the end of the thing? I'll take some questions, and I want to frame those questions, if there are any, by saying that as you look at the various strategies and as you look at the need for UK healthcare to continue to grow, there's another saying, there's no margin, no mission. The other is, no growth is long-term death. And so growth is important. And so in order to understand how much growth, how quickly and scale, how much scale you need to create, we look at different strategies in these 6 boxes, if you will. Are we looking to create access, geographic access? Is that really what we're about? Are we is this initiative about improving community health and creating a larger UK healthcare community? And you see clinical and other competencies, building talent, as Eric talked about, lower unit costs, and then ultimately, over the long haul, creating enhanced and optimal access to capital so that as your strategy continues to evolve, you have access to the needed capital when you need it and at a reasonable and affordable cost. So let me stop there and take any questions you might have.
I will open it up for questions, and I'll ask the first question. Medicaid directed payments. I know what we feel about the long-term viability of those payments is you deal with, let's say, hundreds of institutions. Mm-hmm. You have an opinion. Is your opinion such that sort of the cat's out of the bag and you can't put it back, or are these payments in jeopardy at some point?
Well, I would put it into 2 different categories. Supplemental payments are in that category of cats out of the bag. So in my opinion, under almost any circumstance, because supplemental payment structures are in place in virtually every state, they will continue. The unique aspects of the directed payment program are likely to continue. And the reason I say that is because in Kentucky, for the other hospitals in Kentucky, there's also a supplemental program that mirrors to some extent that the directed payment program. It's not as extensive, Mark, I think that's a fair statement. But we're seeing similar programs happening. For example, in the Commonwealth of Virginia, they're working on taking what they have as supplemental payments and expanding on it. And it's through the combination of the way the money flows and then the structural integrity of the payments back from the federal government that says that for the near term being the next probably 5 years, I think it's safe to be comfortable with the directed payments. Beyond that, it's hard to know. it is hard to know.
Any other questions?
One over.
Yes, Brenda?
I had the similar question about Medicare. What percent, first of all, are the directed payments to the hospital? And secondly, historically, has there been an attempt to try to shift the payer source, or is that even reasonable to consider?
Okay, so the first question is the percentage.
Percentage of revenue from the directed payment from Medicaid.
Well, the directed payment total, I hope I don't get this wrong, is about $600 million, right? Incremental to what would be under it's called HRIP, is the state program. That's probably $350+ million of incremental payment. So it's not insignificant. And it's a benefit that's unique, again, to UK healthcare and to University of Louisville, that should be fully taken advantage of, to use to build new programs, to build teaching, research, all the things that it was intended to support. So I think that's your first question.
Correct.
Right. Now remind me again of your second.
And the second question is, has there been an attempt, or does it make sense to attempt to try to shift your payer source, different types of patients with different funding for their healthcare?
So from a crass, purely financial perspective, of course, the issue is that you have two types of patients, right? You have governmental payment, and then you have commercial payment. You have the ability to sit directly across the table from your commercial payers and negotiate rates. You don't have that ability, technically, to do so for Medicaid and Medicare. So generally speaking, you would want to move payer mix towards the commercial pay. But you have to, and that's a purely financial answer. Looking at it more broadly, you have to look at what is the mission of the organization, and how do you find a balance of payer mix, at the same time providing the appropriate access to the levels of care that you uniquely can provide. And so I have other university hospital clients who basically are almost all Medicare and Medicaid, because they're the only organizations regionally that can provide the care they can provide. So they bring those people in to provide it. That's their mission. And in some cases, they get additional subsidy from the state, and in some cases, they don't. So it's a more complicated question than just a single perspective can give you an answer to, but it's really a balancing act that needs to be gone through. And that's part of what the strategic financial planning process is all about.
Yes, Dr. Swanson.
I have a similar question. So as you move from the facility-based structure to a consumer-based structure, then it's not a natural assumption to think that that percent of directed payment is going to follow. Is that clear?
Well, there is a volume aspect to the directed payment, but to the extent that, well, in the situation here, again, crass approach to it, if 100 patients could be moved out of the hospital to get care at home or virtual care, there are 100 patients who need access to the inpatient facilities that would fill that right back up. That's the issue. And it's not just here, by the way. When we talk to academic medical centers across the country, they are almost all running at capacity, because they are providing a level of care no one else is able to provide or financially can support. And so the ability to move patients from inpatient to outpatient, from outpatient to care at home, that just creates, and you'll hear about this in the next hour and a half, creates new capacity that is vital for the community. And to some extent, to the extent that you'll hear about length of stay and the need to to move patients to post-acute settings. You reduce the length of stay, you create capacity without having to spend any capital. And then you can talk about the new volumes of patients that should be seen at UK Healthcare but can't be seen. And that's the transfers. You'll hear about that too.
Yeah, we have an entire section dedicated to
Yep,
that very
that'll be
subject.
coming up.
Yes, Dr. Shepard.
Since you were a consultant with us before Epic, what do you think has Epic helped us? It was a $300 million investment.
Yeah, well, to some extent, the answer is probably yes. And the investment in Epic or Epic-like tools is a cost of doing business, first of all. Having the data, having the interactivity of the data, physician to nurse, clinical side to business side, so forth, is absolutely vital in terms of creating the opportunity to improve communication, to improve care, to improve productivity. My understanding is that it has been a positive here. I have worked at plenty of places where it hasn't been, and they're very vocal about it. But that turns out to be much less about the tools than about the underlying processes and management. But here, my understanding and my observation is that's been a positive.
Yes.
A quick question. I guess we've asked you a few about directed payments, but you showed 2 slides that showed the margin sort of with directed payments and without, and you alluded to the fact that a lot of the medians that you've compared with are going to be in environments where they're also receiving supplemental payments. Which ones, like the apples to apples comparison, do those medians have supplemental payments in them or not?
So the apples to apples would be without the incremental supplemental payment. That doesn't negate the fact that you get that payment. And my underlying point was that payment is there, and it could be optimized, maximized, whatever, by all the things you'll hear about later today to improve efficiency, improve productivity, and take advantage of the fact that you're actually getting that revenue. Had you not been getting that revenue over the past 5 years, this would be a very different conversation. No.
So, Josh Propton.
Yeah, quick question, and this may be addressed later. You just alluded to it, and when we talk about either productivity, efficiencies, you've got that up here. The slide earlier that showed the expense per adjusted discharge, it's a pretty big difference, no matter which comp you look at, but especially against the academic medical centers. Other than length of stay initiatives, are there anything unique about UK that's driving that difference?
Yes. One thing to point out would be specialty pharmacy. So it's in the revenue, it's also in the expense. And so the cost of the high cost of those specialty drugs is in that total cost of care. That be a fair statement? Okay. So it does skew a bit. The point being that that's one of the areas that you may be able to find some enhancement, improvement in. But again, you have the revenue also flowing in to cover that cost. And so specialty pharmacy is a profitable activity, but it does show up in the cost.
We'll move on. Dr. DiPaolo. Thank you, sir.
Thank you.
Thank you, Jason. Chair Brockman, we're going to go ahead and, with your permission, move on to the first theme, and we'll go through each theme. Okay. So theme 1, as you've heard, is our focus on advanced subspecialty care for Kentucky and beyond. What you're going to hear, we have a number of speakers, a number of the leaders coming up in sequence, is why we are essential to the state. And you've heard a number of different components of that already. Obviously, as an institution that needs to continue to say yes and grow in the number of patients that we can receive here in terms of capacity. So we're going to focus on a number of aspects, and you'll hear that in these next series of talks and the data that's presented on capacity in a non-competitive way or non-competitive approach with partnerships. We're going to pay attention to infrastructure You're going to hear about what we're planning in terms of surgery, endoscopy, obstetrics, and women's health, pediatrics, and where we're going in terms of increased beds as well. I'm going to ask Pete Gilbert to come up and start out, and then we'll do that in sequence, and we'll make sure there's enough time for questions at the end of this theme in this session. Pete?
Thanks, Bob. And thank you for your time this afternoon. You've heard it said many times today that our primary mission is to ensure we're providing advanced subspecialty care so that no Kentuckian needs to leave the state for the care they need, no matter what illness or injury they have. And that's something we extend to all of our family, as you heard, and to the immediate neighborhoods in which we work and live. So let's turn our attention a little bit to the numbers to understand our inpatient capacity. And as we go through these numbers, what I'd like you to think about is perhaps one of the best ways of understanding our capacity or our success in providing advanced subspecialty care is looking at the access or lack thereof to inpatient care. So if you think about the sickest patient, the most injured patient, that patient is overwhelmingly going to wind up in an inpatient setting. Okay, so that's where we see our most severe illness and injury, if you will. What you're seeing here is the actual discharges we've had as a health system for the last 6 years. And the final column on the right is our plan for FY 2024. And what you can see in 24 and in 23 is that we're reaching historic highs. We're over 41,000 discharges a year, very significant number of patients moving through. That's some of the good news. Now let's move on to all these transfers we hear about so much every day. And I apologize for the eye chart. The next 4 eye charts are of the same format, and I promise I'll simplify it real quick. So what you're seeing here is the total transfer requests we get by month for the last 4 years. And a transfer request, just to clarify, is an outlying hospital somewhere in the state calls us and says, we have a patient, they're sick or injured, they need a higher level of care than we think we can provide, we need to send them to you, okay? And you can see by month how many times that's happening each month of the last 4 years, approaching 2,000 times a month, by the way. The gold bar is this year. And if you look at March, let's hone in to be specific. In March of this year, that happened about 1,900 times. 1,900 times we were called and our transfer center was told, we need you, okay? So let's take a look at how that plays out. This is the next cut we look at. These are transfer requests where we've accepted the patient. We've said, yes, send them, and they've arrived, okay? So the data's formatted the same. And let's just look at March. I don't want to make this too complicated. You see in March, we had over 1,500 times that we were able to say yes, and the patient got to us, okay? Remember, we started out at 1,900 asks. We got yes, and they're here 1,500 times. So let's see what goes on from there. Now we turn to the less good news. So this chart is showing you transfers that we lost due to capacity. The outlying hospital called, they said, we've got patient X, they need your care, and we had to say, we simply don't have the resource to take care of this patient, send them somewhere else. Overwhelmingly, right, that reason is capacity. We don't have a bed to put them in. And so what we track every day, and a team of us look at these numbers specifically every day, is when was a patient not able to come here because we didn't have a bed. By the way, for those of you that are noticing the green bars of last year have some really enormous spikes, that's when the entire South was experiencing a very significant COVID surge. And in fact, a lot of the difference between other years and last year was out-of-state requests. So we had requests from Tennessee, Georgia, you name it, to send patients here. Everybody was jammed, and it was a very significant time. But let's look at the gold bar. And I hope what you're seeing is the gold bar is actually getting a little bit better as the year goes on. And we'll talk about March again. 188 times we had to say, no, we're sorry, we can't take that patient. That's about 6 patients a day. And I'd ask you to hold on to that number for just a minute as we move on. This is my last eye chart, so I'll finish up here. This is a really important chart. This is showing you the number of transfers where we said we'll take them, but the patient didn't arrive for one reason or another. The overwhelming reason the patient didn't arrive is because we could not produce a bed fast enough to satisfy the patient and the outlying facility's need to get that patient here in time. What does all that mean? So it's about 2:15 right now, if I'm guessing the time right. And our transfer center is getting a call. And let's say that call comes in and they tell us they have a patient that needs neurosurgical care. I see Dr. Van Horn, so I'll use him as an example. Dr. Van Horn and his team say, great, we want the patient, we're here to help. And we tell the outlying facility, we will have a bed ready this evening, we hope, to be able to take your patient. Well, an outlying facility considers that a slow no. And I think all of the physicians in here are very familiar with that term. What it means is that that outlying facility wants to know, yes, we've got a bed, send them, you can take them. Here we're saying we think we can get them in and it's going to take a couple hours. That outlying facility has to decide, can they wait, can they not wait? The patient's making that decision as well. And we've lost that patient, okay? So follow all the charts again, and in March, that happened 215 times, which is about 7 times a day. So remember the 6 I mentioned where we had to say no because we absolutely didn't have capacity. Then you've got this 7 where we're saying, yes, we'll get them in eventually, and they didn't arrive. That equates to 13 times a day that happens. Doesn't sound like a lot. That's almost 5,000 patients a year who are not getting here for their care. Okay. And if you look at our trend and just assume we keep the same pace we're going to hit 6,000 patients this year that we could not admit because we did not have capacity. And what I want you to remember is that this is 6,000 patients that are in another hospital. They're not at home. They're in a hospital, and that hospital is saying, this patient needs UK, and we're not able to meet that. So if you evaluate, how are we doing at meeting our mission of providing advanced subspecialty care so that no Kentuckian needs to leave the state, we're coming up short. We need to increase our capacity. We have to increase that physical infrastructure so we can serve Kentucky's needs. And you're going to hear more later in the afternoon about how we propose to do that. Now I'd like to invite up Dr. Colleen Swartz, who's going to talk about post-acute care. Colleen? Dave, I think we're holding questions till the end, but I'll defer to Chair Brockman, of course.
Yeah, let's hold it to the end. Let's keep moving.
So I have, good afternoon. I have the privilege to talk about post-acute care and follow Pete's overview of transfers. I don't know how many engineers we have. If you're a fan of a queuing model, I just have to mention that this is one of our inflow elements. 1, transfers, vitally important, but our access also is for subspecialty care for surgical subspecialties. So we have transfer requests coming in, patients coming out of our operating rooms, cath labs, the endoscopy, advanced GI suites. All of these are sort of competing priorities, as it were, for a fixed number of servers, beds, for us to care for these patients. So this is one element of a large system with a lot of inflows coming in. The other thing I would remind you is in terms of post-acute care, and we're going to frame this as patients who are leaving our facility, going somewhere else other than home. They may need inpatient rehab. They may need a long-term acute care hospital. They may need a skilled nursing facility. So these are patients that have to have a discharge transition to somewhere other than home. Until King's Daughters became part of our family, UK Healthcare owned none of those assets. We don't own rehab hospitals, nursing homes, LTACs. We own none of those. So we are working through partnerships in that space primarily. So access, partnerships, key elements for us to be successful in these post-acute transitions. So we've developed a patient progression model that includes elements of progression through our system as soon as patients hit our doors, really as soon as there's a request for care. We're going to focus on the discharge transition into post-acute care. So there's a lot of other work going on in terms of transition planning, standard work, protocols, care pathways for patients who are scheduled, come into our system and go home. These are patients that come in and are going to have to go somewhere else. We're going to use a key statistic called opportunity days. Talked a little bit about this before. Again, we use our Vizient data, compare severity of illness, like illness severity, look at the mean length of stay, similar patient cohorts, and are we more or less effective in those cohorts? So for post-acute care, rolling 12 months, we've accrued about 27,000 opportunity days, which if we manage that down to a similar academic medical center, we could care for about 3,500 more cases if we ratchet that down. This is just in the post-acute transition. In February alone, we had about 3,000 opportunity days. If we manage those down, we could take care of almost 400 more patients. That's a census of about 14. It doesn't sound like a lot, but 14 more beds, as Pete mentioned, creating our internal capacity could make a big difference. So for February, this is just an example. You can see the trend in monthly opportunity days. We have been bearing down on this more than we ever have. I would say Mr. Gilbert and Dr. Greider encourage us to work the post-acute care environment. You can see we're making a lot of progress, and then we've bumped back up in January and February. We've had a real focus on patients with long length of stay. And in your mind, you might be thinking 20, 30 days. So I'm talking about patients who have been in our system for 200 days with nowhere to go. And so we've really been pushing those down into an appropriate safe transition to free up more capacity. You can see where a patient who's been here for 150 days, if we could free up that bed, we could turn that bed more frequently for more patients, right? So we've really pushed on that. We had a peak up in February. We discharged a handful of long length of stay patients, 100, 150, 200 days, and that is what was hitting in February. So this is where we get the census of 14 by allowing more patients to be served if we can ratchet down the opportunity days as they transition into the post-acute care environment. This again is sort of the model. We do have not only an adult progression model, but also one for pediatrics, because the pediatric needs in post-acute care are very different than they are for adults. So they require very different strategies for us to help children transition to another environment if they're not going home. What do we wrap around those children to have a safe transition of care? We have a number of strategies around that. And here are just a few of our efforts. So you're like, what are you doing about it? What's happening around post-acute? We're working on technology, some overlays to help us identify early what patients may need. We have a complex length of stay team. The patients I just talked about, we have a team that meets, we met today to look at all the patients who have been here longer than 25 days. What do they need? What are they waiting on? The key question is, what's keeping them in the hospital so that we can attack and arrange for those things? We have a number of pilots going on. We're using a physical therapist with the trauma service, again, to look at early identification of needs and planning so that when patients are medically ready, they transition to the next phase of care. More on capacity from Dr. Jay Greider, our Chief Physician Executive and Chief Quality Officer. He's going to talk about surgical capacity.
And let me say to the board and community members, write your questions down. We're going to, in about 3 more speakers, we'll open up the floor. Thanks.
Thank you, sir. So last evening, I was on the sideline of a soccer match, and a teen goes down with a fracture. And I hear the parents who are from Louisville say, "Where do we go?" And the the statement unanimously across the sideline was there's only one place that has pediatric orthopedics, ortho trauma, and ortho hand surgical services on call. You got to go to UK Healthcare. That person was in and out within 3 hours of UK Healthcare seeing them. It was pretty amazing in the fact that we were also managing lots of traumas and divert. Throughout this retreat, you're going to be hearing about the empirical information about what makes an academic health center. But one of the key things where there's actually numbers attached to it are the things that are surrounding academic health centers' surgical services. There are prescribed numbers of services that you have to have and provide in order to be classified as an academic medical center in surgical services. So looking at the data about how we are doing within that, keeping in mind, as Mr. Gilbert and Dr. Schwartz just pointed out, a lot of the requests that come into us, last night I was the CMO on call, there were 9 calls. They all had to do with surgical emergencies that needed to come to UK over and above what the transfer center was managing. So what are our surgical platforms doing? Since 2018, we've had about a 14% change in surgical procedures that are done in the university. Over 33,000 cases in 2018, now over 39,000 cases. You also have to remember that embedded within that are the COVID years where the operating rooms were either limited or shut down. We were still doing tons of cases during that time because of the trauma and the acute nature of what had to be done. Remember, elective shut down. We were still doing lots of surgery during that time because it wasn't elective. It had to be done. It couldn't wait. Within that, there was also a bit of a pause on hiring because nobody could interview for jobs, but we are now in the mode of aggressively recruiting proceduralists, as you'll hear from Dr. Conwell in a moment, and surgeons across our entire surgical platform. Where are the utilizations particularly high? In our neurosurgical teams, in our orthopedic teams, in our transplant teams, in our trauma surgical teams, high utilization, the need for more space to take on more Kentuckians. And I just mentioned transplant. Let's go a bit deeper into that one particular service. You see in the graph on the right that University of Kentucky performs almost 2/3 of the transplants within Kentucky. You see growth in our transplant liver program, in our kidney program, which is often sometimes elective, but huge growth. We've just passed 500 milestone of cases done in our heart and our lung transplant programs. So growth in these highly complex, highly specific transplant programs. Now, not only are we a program that is putting organs in for patients, we are also a major donor center. What does that mean? Right now in our university hospital, there are 1 to 2 patients that we are managing that are highly complex because they're very unstable, so that their organs can go across the entire region to provide life-saving care for patients all over the region. That 1 to 2 patients takes up a lot of our resource, a lot of our intensive care work. So we're not only implanting organs for Kentuckians, we're also distributing organs for the entire region of the South. One of the key things that I want to draw your attention to, an academic medical center provides the clinical research at the bedside. I want to call out Dr. Roberto Gattali, Dr. Frances Marti, who are in the Department of Surgery. They're coming up with an innovative process to work on T-cell mapping. The goal of this, one of the real problems with transplant surgery, is the immunosuppressive drugs, which are life-saving to the organ, but are sometimes damaging to the patient's health. They're coming up with ways to avoid those immunosuppressive drugs that are really key to not only surviving for the graft, or what we call the organ, to survive longer, but for the patient to not become sick from other issues. So what you'll be hearing later on within the presentation is a request to expand our surgical capacity. Now, the Chandler Hospital was built with great expansion capacity built in. There were many shelled-in areas, and the last of the procedural and surgical shelled-in areas are 15,000 square feet contiguous to our current hospital operating area, which we will be talking about expansion into. This will provide 8 more operating rooms and perhaps hybrid operating rooms for complex cases to be enacted that would come online starting the process of building in 2023 and opening in 2024, which will allow some breathing room for our surgical services and for our surgical recruitment to continue. With that in mind, we're going to hear more on the procedural side from our Chair of Internal Medicine, Dr. Darwin Conwell, who will talk about endoscopy. Dr. Conwell.
Good afternoon. Thank you, Dr. Greider, for this time. I want to just thank President Capilouto and Chair Brockman and the board and the Healthcare Committee for giving me this time to speak. I do want to take a sidebar and say I've been here for 1 year, and it's been a great year. It's been an honor to be here working with all the leaders here and providing healthcare for the citizens of our great state, Kentucky. And of course, as I said a year ago, my ties are in Trigg County with tobacco farmers and my grandfather growing up here. So let's start our discussion. So this graph, this figure shows volumes that have markedly increased here at our healthcare system. This actually shows volumes of endoscopy that have doubled over the past 3 years since 2020. And in our Lexington Surgical Center, the volumes have increased 3.5 times in the outpatient ambulatory site. So there's a big need for access, a big need for endoscopy and procedures here at the University of Kentucky. So we believe this justifies a discussion with you about the need to expand our routine and advanced endoscopy services. And expanded access for routine advanced endoscopy services can provide and promote and support the growth of multiple subspecialty programs. The growth placed on UK healthcare's overall endoscopy services has outpaced the ability to meet the demands of our population. Now, this contributes to an overall increase in inpatient length of stay, and you've heard some comments about that earlier. It also increases our outpatient wait times, which is we want to definitely not, we want to minimize that. This also increased demand for routine endoscopy service will only continue to rise in the future for several reasons. One is that there's a lower age recommendation for colorectal cancer screening. It's now lowered to 45 years of age. So millions of more people across the country and hundreds of thousands of patients here in Kentucky will need endoscopy services. In addition, our Markey Cancer Center, which is with our NCI Cancer Institute designation and pending comprehensive designation, will expand our clinical care. There will be exponential growth in Markey. This will lead to multiple research trials, clinical trials, and so we're going to need to be able to service patients with cancer here in the state of Kentucky. In addition, as all of us know, there's still COVID catch-up to do. Patients did not get routine endoscopy during a lot of the COVID years, so we still have work to do in that regard. There are two major leading constraints to our problem with increasing our demand and supporting our future growth. Number one, there's an aging infrastructure that we have here at our healthcare system. In addition, there's inadequate procedural rooms and support space. And they've all heard me talking about this and how we really need to grow and expand this service line. So pending approval, construction will begin in July 2023 with an estimated completion in the summer of 2025. And we believe this capital project will establish space primarily for advanced endoscopy services, but also contribute to increasing access for routine endoscopy on the first floor of PAV. So thank you very much for your attention and listening to us. I'm going to transition this to our chair of obstetrics and gynecology, Dr. Roan.
Good afternoon. My name is Brian Roan. I'm the acting chair of the Department of Obstetrics and Gynecology. Thank you for having me here today to discuss our proposal for renovations for Chandler Hospital maternity services. Wrong way. As you can see from the graph, we've made purposeful efforts over the last few years to increase our ability to care for the volume of patients that need or want our obstetric services and expertise. This has resulted in a 25% growth in births over the last 5 years. However, what you cannot see on this graph is the clinical activity that's associated with these increased deliveries. Each year, we also admit around 900 patients to the hospital, many of them transfers from other places in Kentucky, who are ultimately discharged and continue their pregnancy care in our own ambulatory services or in their Kentucky communities. We handle about 4,000 visits in our OB triage that is really meant for urgent or emergent care, medical care for obstetric patients. All of this clinical work is currently done in 12 labor and delivery rooms, 17 postpartum rooms, 12 antepartum rooms, and 4 OB triage rooms. These rooms are outdated and inadequate to meet our expectations of our patients and the care models that our obstetrics and midwifery teams are trying to achieve. This is why we're proposing renovations to our maternity services inpatient footprint. Our department believes in and feels deeply connected to the Strategy 2025 and beyond concepts that you will hear today. We will always offer advanced subspecialty care in obstetrics and for our fetal patients. Our maternal fetal medicine specialists are dedicated to this goal, and we want to make sure that our facilities align with the unique needs of pregnant patients and their babies, while fostering the capability we have of providing outcome-changing, multidisciplinary care in collaboration with our adult and pediatric teams at UK Healthcare. Our general obstetrics and gynecology faculty, along with our midwifery teams, strongly believe that we need to have the ability to fully take care of our people, which include our campus employees, people in our Lexington and surrounding communities who seek out UK Healthcare for high-quality obstetrical care, and women in our community who are not able to get the prenatal care and obstetric care they deserve anywhere else. These two arms of Strategy 2025 and beyond should not be competing, and they do today, but rather they need to be synergistic. By renovating our maternity services, I believe we can offer the best care possible to our patients and ensure that we're fully equipped to continue to take care of our community, Kentucky, and beyond. Thank you for considering our upcoming proposal. I'll turn the floor over to Dr. Scotty Day, the Chair of Pediatrics and Physician-in-Chief for Kentucky Children's Hospital.
So, as one of the board members, I am that passionate pediatrician that always comes and speaks every once in a while. But President and Chairman Brockman, thanks for having me today. And I promise, I realize brevity expression presents clarity, so I'm going to try my best to stay on top because I get pretty passionate about some of this. So, as you know, we were here 6 months ago and we talked about the 25th anniversary. And I think to build on some of the talk about standing on giants and standing on shoulders. So I'd be remiss not to talk about Dr. Noonan, talk about those kind of people that are pioneers, to see where they were, what they kind of envisioned at that point, and where we are today. So a record year for volume. This is unlike anything we've ever seen in children's. And really, just to give you a little insight of Kentucky, only 1 in 4 Kentucky counties have a pediatrician. That's amazing, right? That is unbelievable to think about it. And we have a very high rate of preventable disease. This type of volume, this type of daily census, we are continuing to see, and it's impressive. That's a little bit of the story. The other part of the story is the amount of diversions. In the fall, as you saw a little earlier by Pete Gilbert, we had a lot of diversions. In the fall, we diverted 250 plus children away from UK. And just to give you a little insight, that is a record number of diversions. And we had children that went as far as Massachusetts and as far west as Missouri and as far south of Georgia from Kentucky to seek childcare, to seek some types of children's care. And there's a multitude of reasons really that's happened. One of the reasons is there are very few pediatric beds. If you think about it, there are hardly any pediatric beds in Kentucky. So we are humbly very gracious to be able to have that responsibility, but we also have to be able to meet that responsibility. That's our expectation, not just as the University of Kentucky, but that is our expectation as a state. So we worked with the state and we say, you know, life's deepest meaning is not in accomplishments. It's about the relationships and the partnerships that we have, right? And you're going to hear a lot of that in children's. Actually, there's no deeper place, I feel like, that we have partnerships than in children. So we worked with the state. We said we are overflowing in our ER. We cannot continue to divert these patients. So working with several individuals here, several individuals with the state, actually working a lot with our social services, working with the cabinet, working with the secretary. I could go on and on. We had to figure out a way to make this happen. So a crisis plan was enacted. And what you're looking at is that we have hallway beds in the pediatric ER. We actually converted an adult unit to be able to be a pediatric acute care. And if you remember, there was the COVID-19 emergency overflow space. We had to work with the state to say, we have to open this space for children. We cannot leave children at these outside facilities. There can't be a situation where these children are really waiting to go nowhere. We have to be open. And I'll give a big call out to so many people that were part of that, including a situation where that every morning there's a phone call that happens to talk about what is children's capacity across the state of Kentucky every single day. And our leadership team's part of that. And we're very proud to be able to bring that together so we can figure out what to do with these kids. So I'm going to talk a little bit. You heard a little bit about Dr. Rohn talked a little bit about maternal services. Just to give you a little bit of insight into the NICU and a little bit into our neonatal services, 2021, 1 in 8 babies were born preterm in Kentucky. 2021, 1 in 11 babies were low birth weight. We are seeing higher acuity newborns making up a growing proportion of our births. If you look over, Dr. Conwell has the size of it as a Diet Coke can. We had a baby 350 grams discharged from our NICU. What an accomplishment. Like, this is not just us being able to take it, it's pushing the envelope. It's really building that academic center. It's building the research to be able to take care of a 350 gram infant, to be able to resuscitate a child that's 22 weeks. I mean, these are amazing things. And we talk about these kids go home. Now, some require longer terms, but these children may spend 200 and some days that people don't think about. Well, how can someone spend that long? Well, if you're the size of a Diet Coke can, it's going to take you a while to get big enough to go home, right? And so when you think about that, that is a part of it. And then how do we wrap around these families to say, we're going to give you the resources to be able to take care of that Diet Coke can when it becomes a much larger can, right? Maybe it becomes a 20-ounce bottle, I don't know. But part of that is really being able to provide those resources, right? In a state that has a lot of challenges. And so some of this, we've increased our NICU beds from 70 to 90. In January of 2021, we opened a neonatal abstinence syndrome, and there's a lot of research and academic work, as we talked about with Dr. Cassis, with our research growth in pediatrics and neonatal. A lot of that work is really looking at that population. So how do we make Kentucky healthier, right? We're talking about this strategy refresh. We're talking about how are we going to make the future healthier. And a lot of times I compare it to, you plant a tree, right? You may not see that tree for 20 years. You got to nurture it. You got to take care of it. And to be honest, you won't even see what happens to it 50 years from now. This is what our mission is all about. It's about planting that tree, making sure it has the resources to go along. And it's not just the University of Kentucky and Kentucky Children's Hospital's mission. This is part of our responsibility to the state. And it's written in the state health plan that we will provide oversight, subspecialty access, transport, education, and quality reviews for the perinatal outcomes. Why is that so important? There's 2 level 4 NICUs in the state of Kentucky. One's in Louisville, one is here. What's our responsibility? We have to figure out how to improve the outcome. March of Dimes said that the state of Kentucky ranks F for preterm. It's not ranking our level 4 NICU. It's just talking about the preterm birth, the state of the moms, and the health of Kentucky. And they're saying you guys have to be a part of that. And we are a part of that. And some of this is through partnerships. We actually staff pediatricians, we staff neonatologists regionally through some professional service agreements to some of these institutions. Also, we work very closely now with King's Daughter and that group to be able to figure out what can we do to drive outcomes. That does not mean every single neonate comes to the University of Kentucky. It means we work to figure out what is the best way to take care of these babies. I would be remiss not to mention a little bit about our behavioral and mental health crisis response as well. As you guys probably realize, for the first time in decades, the mortality in children between the ages of 1 and 18 increased. We haven't seen that in many decades, and there's a multitude of factors of that. I want to call out some great work by Dr. Himmelhoek, who's the chair of psychiatry, working on some multidisciplinary teams to be able to consult, to allow us to do behavioral health treatment. We've opened some intensive outpatient services. We really focus on some of the depressive disorders. We're expanding partnerships in the schools. So just so you know, we're not trying to go at every single school, but I can tell you we're a resource. We get the calls. Our teams get the calls of what are we supposed to do in these situations. So in many ways, we may not call it a center of excellence, but in many ways, we are trying to be that integrated clinical center to be able to give them the resources. It doesn't mean we're in every single location or every single school, but we've got to be there. And this is not only important for the schools, it's important for the future workforce. There was an earlier discussion we had about workforce. This is how we make a strong workforce long-term. I'll call out the behavioral health transport service. It's a transport service that Colleen referred to briefly. And really what that is we don't want our critical care neonatal transport team transporting patients with behavioral health needs. We need them to go get the NICU baby in Ashland or Pikeville or Bowling Green, right? We want a separate service for that. And that's been very successful to be able to do that. So what is the planning for growth? And one of the things I'll tell you, one of the proudest things is that we are expanding. We're taking care of more children in Kentucky than we've ever taken care of. And there's not a bigger honor, right? There's not a bigger responsibility. From Dr. Greider's comment about being on the soccer field, I mean, what a great, really kind of a thing to say, you know what, go to where we are. And I'll tell you, we've recruited 60 plus faculty in 3 years in Children's Hospital. So this just isn't certain surges. We're doing more complicated things than we've ever done in Lexington. And I'm very proud of it. And if you ask me how we did that, we didn't say, hey, what does Kentucky need? We often ask these people, what makes you come alive? And we have these programs because ultimately, as someone's told me here before, you recruit this person to be here and this will be their last job because they're going to fulfill what they want to do. So NICU, PICU, cardiac ICU, acute care, behavioral health, and emergency care, record number of ED volumes, and unified pediatric ambulatory center. We need to co-locate our talent for efficiency and access to care. And I have to call out one of our big relationships here with the Ronald McDonald House. They are part of our post-acute strategy and a part of us really wrapping around these families. So with that, I'm going to introduce Mark Birdwhistle, Senior Vice President and Chief Administrative Officer.
So I always get the opportunity to follow Scotty Day. That's really a difficult thing. I don't think I can top the Diet Coke analogy. But I will bring you back to a couple of points that you've heard in the last couple of minutes. You heard Pete Gilbert talk about 5,000 plus patients that have been diverted that needed our care. And I use that term, our care. They need our level of care. That's a point that we all need to take very seriously. That's an annual number, 5,000. Then you hear Scotty Day talking about diverting 250 children that went to all of those states that he mentioned. And I can't help but think how I would feel if those were my grandchildren having to be diverted in that situation. I will say, this is exactly the same message that we are hearing from our state officials, our referring hospital systems, and our referring providers. It is their expectation that UK will always be that destination center for advanced subspecialty care. And I think President Capilouto alluded to that very eloquently in his opening remarks. So, what are we going to do about it? You want to know, how are we going to handle that? So, we have very pleased to say that on yesterday. I'm very proud of our team to put the application together in a few short weeks. We submitted a certificate of need application to the Cabinet for Health and Family Services for an additional 300 beds that we hope will cover us for the next 10 years. I'm very proud of the work that's done. A major focus of that application has a pediatric focus, also a behavioral health focus to address the crisis that we have in front of us. I'm also very pleased and somewhat overwhelmed that with the level of support, of letters of support that we have received all across the Commonwealth, east, north, south, of health systems and provider groups that were willing to go on paper saying, we support UK's application. It is the health system's responsibility to be that provider for the Commonwealth. And if we don't do it, I don't know who else will. So with that, I'm going to turn it back to Dr. DePaula, who will kind of bring us to the close of this theme number 1.
Thank you, Mark. So just to look at a couple of concluding thoughts after this session on theme 1 related to advanced subspecialty care for Kentucky and beyond. Obviously, the demand we have for patient care exceeds capacity for UK Healthcare's advanced subspecialty services. You heard about a number of very intentional efforts related to enhancing what we can do in surgery, endoscopy, obstetrics, and women's health, pediatrics, and an increase in beds. Obviously, UK Healthcare is asking for state approval for the additional 300 inpatient beds, as Mark pointed out as well, and proposing renovations, and you'll see that in the FCRs later. I will stop there and turn this back over to Chair Brockman for questions.
The floor is open for questions. Again, we can question any of the last 8 or 9 speakers. If you wrote questions down, Dr. Swanson.
I have 2 questions. One has to do with endoscopy and the other one has to do with maternal health. So with respect to endoscopy, it might be wishful thinking on my part, but it is my understanding that in the future, we will rely less on surgical invasive methods for screening colorectal cancer.
Well, that's a very good question. So the question was, are we going to rely less on endoscopy for screening? And that's already happening right now. We cannot keep up with, we can't provide a colonoscopy for everyone that needs colorectal cancer screening. And the best screen is one that gets done. So it's going to be a combination of stool-based testing, serum-based testing to get colorectal screening done, especially with lowering the age to 45, because that's a cancer that we want to eliminate in the world, especially in Kentucky. And we've done a very good job of doing that, but it will be a combination of non-endoscopy approaches with endoscopy. We will still have thousands and thousands of colonoscopies to do for colorectal cancer screening, because once you get that test done, if it's positive, you need a colonoscopy. But the best screening test is the one that gets done. So any gastroenterologist says, I don't want my patient to get a Cologuard or a FIT test, they're living in the Stone Ages. We want to eliminate this cancer. And that's a great way to start. And we have a very strategic plan from the EVPHA to do Cologuard and FIT testing to make sure we elevate our screening rates for our citizens of Kentucky. It's very, very important to do that.
And the maternal health question too, what is the percent of our population of the maternal health? What percent of those people struggle with addiction, and how does that impact our facility needs?
So we have many programs that we have initiated for substance abuse. Up to a quarter of pregnant women in the state struggle with substance abuse, and it's over half the cause of maternal mortality in the state. which Kentucky is one of the worst in that regard. So our department, along with the College of Medicine, has research arms and community service programs that support those patients, and many other healthcare systems will not. And that's a large portion of the maternal transfers we get, and need our adult and pediatric colleagues to help us with their care.
Trustee Melanson.
Going back to Pete Gilbert's presentation, there's a couple slides about folks that we have to either say a hard no or a soft no to. What percentage of those folks from Kentucky hospitals are asking to come here?
I would say near 100%, very high, 90 plus easily. By the way, just to clarify, we don't actually call it a slow no. I think the outlying hospitals experience it that way. Just wanted to clarify that. Thank you, trustee.
Trustee Gosney.
Yes, I have a question about the long-term stay patients. This may be counterintuitive because I know you need additional beds, but my question is, from a financial perspective, have you all considered leasing a floor or a unit to an LTAC to take those patients? So at least financially, that would be helpful. I know they do that, for example, in Northern Kentucky at St. Elizabeth.
Yes. Yeah, it's a great question. And we're exploring some.
Can you explain LTAC?
Sure. LTAC is a long-term acute care hospital. It's somewhere between an acute hospital, think of UK, and then think of something in between where the patients still have fairly high complexity, but they don't continue to need to be in acute hospital. So maybe they're on a ventilator, very stable. They're going to be weaning from mechanical ventilation. They can go to an LTAC. Complex wound care, they can go to an LTAC. So we've talked about firming up the partnerships. Mr. Sussman showed you sort of this continuum of progressive partnering with other facilities. We do have a process where we financially help subsidize some patients' movement, not only into LTAC, but inpatient rehab, skilled nursing facilities, and that kind of thing. So I do think the next, we have a preferred partnership. We're trying to keep our eye not only on care transition, but also the quality of care provided by that partner. We don't want our patients to just go anywhere. We want to make sure that we're referring them to a post-acute care partner that provides really good care. So we're fairly selective about who we work with, but I was just looking at the data for February. We had 9 patients that accrued almost 1,000 opportunity days. 1,000 with 9 patients, various and sundry reasons, right? We couldn't get a post-acute care facility to accept them. They were complex. They had guardianship issues. I mean, the social complexities of some of the patients we have it can be very difficult to sort through that and make sure they have a safe transition.
And as a follow-up, are the long-term acute care hospitals in Kentucky at capacity typically?
We had a serious constraint in capacity with COVID because of staffing. We're experiencing staffing challenges. Many of our post-acute care partners, it's getting better. I will say that. They've opened up more. The COVID testing challenges have, reduced. So I feel like right now we're getting more smooth transitions of care than we had even pre-COVID. So they're getting back to their full capacity, full operations, but they have limited capacity numbers as well. And in terms of LTAC facilities in Kentucky, there aren't that many of them. Sure.
Any other questions? Trustee Shepard.
Is there anything on the horizon regarding AI, artificial intelligence, for either scheduling? It's been touted as the greatest thing. to be able to enable people to schedule more. And I looked up Solus Mammography, and they also, so I was trying to figure out who they were. I had never heard of them, and they boast you have an AI program. Your results are in 1 to 2 days, and it's comfortable. Everything is done quickly and efficiently. So my question is about AI.
Right now, everybody knows me in the back of the room is wondering why I came up here to talk about a technology question. Let me see what I can tell you there. So we actually have a couple of external experts we're meeting with over the coming months that can help us understand better how that could come to play. And I think the number one thing we've got to do as a health system is turn our information systems approach to be one of technology, digital application, if you will, and things like AI, and depend on some of the experts rather than trying to rebuild it ourselves. So more work to do. Yes, I think there's opportunities, and you now have the extent of my technical knowledge.
We also, Dr. Conwell also has an example that ties right into endoscopy. If we ask him to come in and answer that as well.
Yeah, and artificial intelligence is transforming how we're going to be taking care of patients right now and in the very near future. In the gastrointestinal space and the endoscopy space, we have the ability now to couple artificial intelligence with the endoscopists as they're doing the colonoscopy to help them identify polyps. So actually you can enhance and increase what we call the polyp detection rate, which is the precedent lesion that leads to cancer. So AI is coming fast and furious here in that space. It's also helping us in radiology and other areas, but that is something that's going to help us decrease cancer rates in our population.
Any other questions? Well, I got so excited when I was introducing all of our community members that I actually forgot to have the minutes approved at this meeting. So I trust that you've all had an opportunity to review the minutes from February 16th. They were distributed for your review. Are there any corrections or additions? Seeing none, do I hear a motion for approval? Trustee Gohagan has made the motion. Trustee Melanson seconded. All in favor say aye. Opposed? The minutes are approved. We are adjourned until 3:15. If everyone would be seated, please. We'll call the meeting to order. Dr. Monday.
Good afternoon, board. Welcome back. What I ask is for about 45 minutes of your time, and then we'll have another break. But about 45 minutes to talk through theme number 2. We're going to talk about and really dig into how we plan to, how we're focusing on taking care of our people, taking care of our community, and how we're thinking about our talent. And so we have a number of speakers that are going to talk about our talent, our workforce, our pipeline. And then we have some speakers that are going to talk about our ambulatory strategy and the next steps around that. And we'll finish with a couple infrastructure projects specifically that ladder up to the FCRs. First, I want to introduce Ms. Frederick, who's our Associate Vice President for HR, focused solely on healthcare, and Dr. Gwen Moreland, who's our Chief Nurse Executive at UK Healthcare. Gwen?
Thank you, Dr. Monday. I do have to start with a fun fact for those that do not know, but when Dr. Roan showed the slides of that obstetric unit, I was there that day and one of the nurses that originally opened that unit, so you can gauge my age on jewel tones. And if we can get this finally across the finish line, I said I might be able to retire. So come full circle. So I'm here to talk a little bit and kick us off on some workforce. So as we focus on our people, we need to understand where we are today and where we need to be. So you've heard some plans regarding building our infrastructure, building out the completion finally of Path A. The 12th floor will be opening next year. You're going to hear about plans to finish building out the ORs and expanding services in ambulatory and pediatrics. But in order to meet this need and the volume growth we are expecting over this 10-year forecast, we will need an additional 4,800 full-time people. To date, we've been able to meet our mission and care for the people of Kentucky by incentivizing our own teams and then supplementing with agency staff. But as Mr. Sussman referred to earlier, this comes at a cost. Currently at UK Healthcare in all roles across all of healthcare, we have a 23.2% vacancy rate. And that's very similar to what others are experiencing in the region and across the country. It's a struggle. But with supplemental agency staff, that has reduced us to a vacancy rate of 17.63%. And now we need to take some time to really focus on our people, and then how do we begin to rebuild our workforce? And so I'm going to hand it off to Melissa, and she's going to share some of the initiatives we've been collaborating on and where we're starting this work.
Thank you, Gwen. And so last February, we actually talked with you about these projections and also our plans that we had to address them, because we know not only did we have the 4,800 positions that we knew were new to UK Healthcare, but we also had to resolve the existing vacancies. And so we definitely wanted to spend time with you going over what we've done thus far and then what's still ahead for us. The first thing that we talked about is creating a healthcare recruitment function. And I think we can all agree, coming out of the pandemic, it is a very different labor market. It is not a market where you can put a posting up and get dozens of applicants. We must be much more intentional and we must worry about the candidate experience. And to that end, we've actually hired a recruiter for the for the recruitment function, who is assembling her team. She's hired 3 of the 4 healthcare recruiters and has taken oversight of the nurse recruitment team, which is extremely talented, but needs the additional resources. Starting to work on our process and branding, so making good progress there. We also committed to you that as we took on these new efforts, new programs, we would track to make sure that where we were putting our efforts was paying off. And so we are in the process of still gathering together the final pieces of the data efforts so that we can create this dashboard. I will tell you that weekly we're pulling a lot of this information manually, not optimal, but it helps us get a picture of where things are working well, where we need to redirect resources. I think an easy one that we pulled off in last summer was traveler conversion packages. And while we still have a number of travelers, it's still a hot market for travelers, but we have the ability to attract travelers and have been successful in hiring them. And we've extended it to nursing as well as any of the allied and clinical travelers that are on board with us. It really is a small investment to land an employee who is already oriented and familiar with UK healthcare. So definitely something that we want to have as a tool in our toolkit. The other thing that we talked about was really providing some supplementation to our recruiting resources with our many vacancies. And we talked about bringing in a recruitment process outsourcing program, and we've partnered with AMN. And we've actually assigned them over 200 clinical roles to start with. And that is not only nursing, but other key clinical areas such as respiratory therapy, radiology, sonography, so that we can start to get our staffing back to normal. Super excited about their campaign. They're actually working on a Kentucky Roots campaign and are actively reaching out to 1,800 experienced clinicians who have ties to Kentucky. So we're really looking forward to seeing what that accomplishes. Next, we've talked a lot about partnerships, and we knew going into this that we would have to create, not only reinforce our existing partnerships, but create new ones. And so I wanted to give you a few examples of what we have in place as well as what we're growing towards. One of the partnerships that we had was the senior nursing assistant, and that was with Commerce Lexington and a couple of our healthcare partners in the community. We had great success with the program. They were not so hot on it, so we've actually moved on and brought that work in-house. And we've also utilized our new recruitment team that are starting to put together other techniques for reaching out pipelines, such as volume hiring events. And so we continue to be dedicated to that work because those are key entry-level positions that provide support at the bedside to help our nurses. We know we have to get to people earlier in their academic careers. And so we're actually actively working on co-op opportunities for pharmacy tech positions as well as sterile processing, 2 very important entry-level jobs, but we're getting to those where we can get to the students in the high school, let them know about the opportunity, help train them, and onboard them, hopefully eventually successfully into UK healthcare. So very excited about that opportunity. Lastly, we continue to partner with our colleagues in the College of Medicine and really have invested in clinical rotations and faculty funding for registered nurses, as well as with BCTC, because we are dedicated to not only the patient care, but growing of new healthcare talent. And that also has expanded to our respiratory therapy colleagues and is really just a start for where we are at this point. I want to talk a little bit about the new efforts because they're exciting as well. And we've been picking them up and planning them as we've gone along. And the first is we've initiated a referral bonus program pilot. And so that is where we're using our existing staff to help us by referring experienced clinicians in 20 different healthcare titles to be considered for employment. If that person is hired, the referring employer receives a bonus. The first half at the 90-day mark of service and the second half at the 1-year mark. And that does two things. One, it uses our own staff to really help bring the person on, but onboard them because they have a vested interest in helping that person onboard and stay employed. And it's been a very positive program. In fact, we have extended that program until July 1st, at which time we'll step back and assess the titles that we have in the program and see if we need to make changes. We also know that healthcare with our patient volumes, we know we have high patient volumes, but that sometimes they fluctuate. We definitely wanted to make sure that we had programs that we could flex staff. And so to that end, we continue with premium unscheduled shift pay because that's really a win-win. We financially incent our staff to pick up needs that we have that come up quickly, as well as meet our needs or give them additional compensation. It's extending the weekend staffing program beyond nursing, which is a huge help for our patient care colleagues. And I'm especially excited to talk about the educational loan forgiveness because previously it had been narrowly defined to nursing, and it has been expanded for many other allied and clinical areas such as medical lab scientists, many of the radiology professions inclusive of nuclear med tech, CT, MRI. We have sonographers and their respiratory therapy, and it is a good investment for us because it definitely helps us to drive some loyalty and some retention with that forgiveness. We are at this point working on broadening the tuition assistance program. That's in flight right now, looking to focus on similar titles so that we can make sure that we have an additional support to attract those hires. You've probably heard that most other organizations are relooking at how they get the work done, redesigning how the work is done. And UK is definitely part of that. And my colleague Gwen and her team have been spending time on alternate staffing models and really looking at expanding the LPN or licensed practical nurse model in the inpatient setting. The intent really, when you look at the literature, is people really want to operate at the top of their license. They want to be able to do that meaningful work. And by adding this level in, it is really helping our RNs have a better experience in terms of the work that they perform. So very excited about that work. And lastly, we've always got to stay on track with what our competitors are doing. So we've been very mindful to pay attention to the market, especially as it relates to eligible on-call titles. Because again, we are dependent upon our staff to flex both up and down. So we've added market adjustments for our on-call staff. We've definitely recognized the relief that nurse care techs can give to our nursing, and we have actually expanded them into a per diem pool. And we are truly committed to our new grad nurses and having that be a pipeline as well, because we are also responsible for growing that new talent. My final slide, I want to share with you over the past 4 years that we've spent over $63 million, and that does not include the 4% increase that we gave in November of 2022. But you can see that nursing is a constant over these several years. However, I do think it's important to note that as we look at this, there are other non-nursing roles. So we have been mindful to be looking across the enterprise to say, where do we need to give attention? Where do we need to make adjustments? I will reference a few key points, such as in 2021, we did grade and salary adjustments for key clinical roles, and that fell across many of the allied health in addition to nursing. We definitely wanted to make sure that in 2022, we were giving opportunities to retain staff, so we came up with recruitment and retention bonuses. Not all organizations do the retention bonuses at the same time they're pulling the trigger on recruitment bonuses. So that was an important program for us to put in place, but it's based on specific metrics and a business case. And then finally, we definitely in 2023 have continued that practice of actively looking at the market and addressing issues as we see fit. We've done adjustments for not only our patient care staff, but key roles that matter to us, such as our IT and Epic group, and patient care techs, clin labs, and radiation therapy, all very important. So we are doing a lot, and I appreciate your time today. I am actually pleased to introduce my colleagues, Rob Edwards and Tim Gilliard, who are going to speak to us about access. Oh.
Thank you, Melissa. Thank you, Gwen. Thank you, trustees. Tim and I would like to share our evolving thoughts about how we serve this growing University of Kentucky family. Those of us here, the ones working right now in the hospitals and clinics, while we continue to create access for patients with the most complex needs. You all know this is not a new subject for us. We've taken a lot of time talking about how do we correctly serve the right communities in the right places. But when we started this discussion, we started to go through the qualitative process of reviewing our ambulatory strategy. We set some new guiding principles for us. We're not here talking about growing for growth's sake or growing to dominate in primary care, for example. We had some really specific goals we wanted to tackle. First, of course, is access. By enhancing access, we'll create a geographically dispersed network for our UK family and our neighbors. Second, we will go and try to serve people closer to where they live. And by doing so, all of those individuals, sometimes for lower acuity care, won't have to travel onto campus for care. And thus, we can serve more complex patients with multimodality care on our campus. Three, we love our maps here, and I'm actually going to share some. We can't do a PowerPoint to you all without maps. When we think of our four-part mission here, we're talking about evolving strategies to get to a broader outpatient population so that we can attract patients who might be interested in enrolling into clinical trials with our researchers, having experiences with our learners from our 7 health-related colleges. Fourth, as we create these sites, speaking of learners, we want to incorporate learning spaces and opportunities for our students, residents, and other learners. We have 7 deans from our health-related colleges here because their students need these training opportunities. And we expect these new ambulatory sites to serve some of those needs. And of course, finally, this is a team effort, as Tim and I, Dr. Greider, Mark Filburn, Lynn and Allison and many others, we partner up on what this strategy for evolving our ambulatory programs might look like. We want to make sure this is good business and good for patients. We're looking to incorporate things like pharmacy, lab, imaging into some of our new sites to make it more convenient for patients and more convenient for our clinicians. All right, I'm going to take a second and talk about one of the things, though, one of the disturbing trends we've been seeing in the data that really makes us want to focus on this evolving ambulatory strategy. This is the trend of individuals who enroll in UK HMO benefit, healthcare benefit, or UK PPO benefit. So what's that mean? As a core strategy, the university and the academic health system, many years ago, teams put together a self-funded, closed network offering at the lowest possible cost. Thus a lower premium plan. But you have to, of course, in an HMO model, seek care within a closed network. So individuals who choose UK HMO come to Chandler Hospital, Good Samaritan Hospital, our faculty practices on campus and at Turfland, but stay within that model for a lower price point. On the other hand, the PPO model is obviously the university's self-funded open network. You can seek care outside of UK, but for a higher monthly price point. These are similar to things in your all's businesses that your employees choose once a year in open enrollment. But look at the trend, and this is not good for us. We want to be the place, the provider for our UK families. Our UK HMO enrollment is declining, and our PPO enrollment is dramatically increasing. We're proud of the care we provide. We need to do better. We need to go to our UK families and serve them closer to their home. And we hope they will choose UK HMO more often than UK PPO. Eric's talked about the intersection of talent, strategy, and infrastructure, and how do we attack that? First, we place care sites close to people, and you can see on the right hand of the slide how we've analyzed our strategic planning team, Dorian Herzig's in the back, how we analyze where are our University of Kentucky families, regardless of HMO or PPO, and where do we go create sites for that access. Tim's going to talk about some of the specifics. But also when we look at these slides,
in maps, we think about where are there gaps in access to care. That these health inequities, so to speak, are things we want to tackle. And then finally, beyond Fayette County, in the broader bluegrass, there's a lot of opportunity for us to serve a much broader population. Jason Sussman earlier talked about build, buy, or partner. We're not going to tackle this entire geography on our own. We might find new ways to partner creatively to serve access, to create new access for patients in the bluegrass to support our mission. Tim?
Thanks, Rob. So many of you may recall seeing this map in previous board meetings. About 2 board meetings ago, it was introduced by our healthcare Chief Diversity Officer, Dr. Takia Talbert. And as we look at expanding our ambulatory network, we must also address our regional health equity needs. A recent health equity survey shows that among the zip codes of Fayette County, there are as many as 11 years difference in life expectancy. Thus, the need for a focus on the underserved communities that you see here in the dark red. Now, our existing and future sites will target growth in primary care providers and in future volume demands. Now, we have historically exceeded our volume expectations in our opening of our new sites. So as we go forward and build new clinic sites, we'll build with expansion of volume in mind. An example is when we opened Fountain Court last fall. Within the first 3 weeks, we were already at capacity for the providers there, although we did have more space that we can grow into. So that's something that we will be cognizant of going forward. In the next 3 years, we anticipate adding about 29 primary care providers in these 6 sites that you see here. Hamburg and Madison are seed sites to support our UK family and our neighbors until we add specialty services in those communities. Then we have already experienced some success in the Frankfurt area. So a community site to support primary and subspecialty care there will provide access and convenience for greater coordination in the Frankfurt area. And of high importance, as the previous map supports, we'll be working with internal groups and community members to identify services and locations to address our most vulnerable populations in the underserved populations of in those zip codes of Fayette County, as I showed before. So this is our process for successfully implementing these sites. We'll start with collaborations with department chairs, division chiefs, Rob's strategy team, and our ambulatory leadership team to ensure alignment. This also includes collaboration with other physicians, nurses, facilities, other strategy teams, as well as other operations teams in our organization. There'll be engagement with committee and functional expertise levels like IT, facilities, human resources, and other subject matter experts in the deployment of these new sites. And then in our final execution of the projects, we'll transition them to our standard operating procedures for management, measurement, and ongoing monitoring for continued success. And with that, I'll turn it back over to Dr. Monday to talk about infrastructure.
Thank you, Tim. Rob, Gwen, Melissa. So a couple finishing slides here in theme number 2. So we've talked about the 4 new ambulatory sites, but we want to talk for a second about a couple FCRs, or one in particular that's in your packet that you will ask for consideration later in the meeting. So this is FCR 13, and this is what would be achieved through FCR 13. So this board has supported and allowed us to purchase 41 acres in Hamburg. We paid $39 million for those 41 acres. And so as we think about taking care of our people and we think about the first use of that Hamburg property, this is what we believe is the appropriate next step. And so we are seeking later in this meeting the endorsement of FCR 13, which would allow us to begin the design of a new medical office building in Hamburg. Think about Turfland sized or even beyond the size of Turfland. And that would be the first phase of our development of that site. So when we think about, and you may ask why in that area, why Hamburg, why in that 40509 zip code? Well, here is some compelling data that supports moving closer to where our employees are. Earlier, I shared that we had over 30,000 members of our HMO and PPO, the slide that Rob talked through. It's actually 32,021 is how many members, how many employees and their families are on the HMO and PPO. 3,346 of those 32,000 live in the 40509 zip code, the highest percentage of member lives of any zip code in the surrounding Lexington area. Adjacent to, of course, 40509 is 40515. That's our second highest population. So we're going to where our people live, where we can serve them closest to the home, as well as to, of course, the surrounding community. You may say, what is going to go into this facility? What's the specialties that are going to go into that facility? Well, we will follow the process that Tim has outlined. We don't know that answer today. We will have an active design and a big table with our administrative leaders, our healthcare leaders, our clinical leaders, our physician leaders, all around that table working together collaboratively to determine, and this is design only. So when we finish the design, we'd have to come back in front of this body to begin construction. Secondly, this board has already authorized, and we are well underway with our Cancer and Advanced Ambulatory Center. And this board supported a material change in this project just a few meetings ago. If you look at the bottom of this slide, the original preliminary plan and stack for the building was about 326,000 square feet. Based on great conversations led by the UK leadership team, UK healthcare leadership team, we were able to bring in front of this body, and y'all supported an adjustment to build over 500,000 square feet on this between $600 and $700 million facility project. So it allowed us to go from 3 to 5, a parking structure from 1,350 to 2,050, as well as the ability, and this is most important, to have a facility with 3 shelled floors. So what we're going to build today is that cancer center, and we're going to have 3 shelled floors for advanced ambulatory. What our priority and when this qualitative refresh, which came to us very, very quickly, is let's move more aggressively than that. And let's look at what we can put into those 3 shelled floors now while we have a design where we're beginning to move dirt, we're taking houses down. And so we will equally work in a team-based approach with our clinical leaders, our administrative leaders, our staff leaders to determine how we finish off those 3 shelled floors. So maybe we can open a facility in the next few years that is actually completely open. You may recall Mr. Gilbert explaining to us the design of this has multiple entries, valet parking, a higher level of ambulatory care and service than we currently are able to provide for cancer and, of course, beyond cancer. Which specialties go in there is what's in front of us, and that's what we would do equally in this design process. So in summary, Mr. Chairman, happy to stand for questions from my 4 colleagues as well. But infrastructure today is easier than talent. We can determine how to build something, the cost, and how to fund that, honestly, in a few hours' work. Finding the talent, building the talent pipeline, sustaining the talent, figuring out a way to get those 5,000 additional positions that Gwen and Melissa talked about is a component of activity and interest and need that is going to take up a tremendous amount of our time. And as we think about that, it is not just our 7 health-related colleges, it is partnerships, it's acquisitions, it's different strategies, because the need is that great. Number 2 is we have to enhance, we have to get closer to our patients and enhance our ambulatory access. So those 4 sites we're moving on. Those are sites that can be up in months, not years. And we're moving on those, and we will move aggressively. We think about how Hamburg is a component of that, and the first phase of Hamburg relates to this medical office building. And lastly, we're going to strive for and build a pro forma in a way in which when we open cancer and advanced ambulatory, that those floors aren't just shelled, that those floors are filled and ready to serve our patients. So, Mr. Chairman, we're happy to take any questions, sir.
The floor is open for any of our previous speakers during this segment. Do I hear any questions? Yes, Trustee Kramer.
Got 2, if that's all right. They're semi-unrelated. The first has to do with the nursing strategy and the increased application of LPNs. I think the state's working with the College of Nursing to try to double the number of nursing graduates. There's going to be some dynamics between the LPN that are in sort of employment markets. Can you comment on sort of how those strategies align or conflict?
So we've really been pretty successful in adding the LPNs back into our inpatient care model. We would like to continue to expand that. Some of that is in a team approach of providing care. Some of that is still in not a team approach, but there are some limitations of the LPN license, and so having some RN oversight of those areas where they cannot. But as we've seen, I think many of the programs across the state are really looking to expand their seats. So we will continue to work with all the programs, and as they're expanding seats, to see what we can do in any way to help with clinical sites and clinical rotations. I know both in our ambulatory and our inpatient areas with our licensed practical nurses, we've really strived to build those partnerships and to provide some clinical site as well. We've found by talking to the schools that if we can provide those clinical sites while they're in school, that we have much more of a chance of recruiting them, getting them into UK healthcare while they're as a student, so that they really see what we're about at UK healthcare and what we have to offer is one of our biggest recruiting tools.
Thank you. The second question, if I may, is about the enrollment rates for the 2 healthcare plans. I think it was suggested that the difference in the enrollment rates is related to access. There are other reasons. Could you comment on perhaps some of the other reasons why people might, I mean, it can't just be there's not a place to go, right? There's some other factors that go into that. Just trying to understand what some of those other factors might be.
This might be like Pete's AI question. Definitely access is part of the question, but frankly, the price point, as you know, is really important. Melissa and I have talked recently about how important top dollar salary is for new people coming into the university versus these amazing benefits we all have access to. And so I would say it's kind of multi-pronged, right? Price and access, and I'm sure other factors.
Yeah, and I think definitely one of the things that we're finding is that it's an entirely different labor market in terms of what they're looking for. And so really probably when you look at a survey that was recently done by Mercer in terms of the state of the workforce, probably 60% of the employees feel like the benefits package doesn't meet their needs because they have very specific needs as it relates to HMOs versus PPOs. There's different tolerances in terms of taking risk for help than they look at different things. I do think our own programs are very well funded, very competitive. It's just the challenge is that people aren't always valuing it the same way that somebody such as me with the boot might value it. And I do have to share that when we had our recruiters for AMN looking at our benefits package, they were so excited. They're like, do you know what an awesome package this is? This part's going to be really easy to sell. Our challenge is people don't always want to drive the Cadillacs. Does that help?
Any other questions? Dr. Swanson.
To what extent are we incorporating the use of robots into patient care?
Dr. Greider?
So within the surgical platforms, there are multiple operating rooms from things as straightforward as hysterectomy all the way up to cardiac surgery, where the cardiac robot program is taking off. So it's fairly extensive in the use of that and pretty well established in the surgical platforms. In other areas, it's not quite as much, but in our surgical platforms, it's pretty sophisticated. So that's really not what I would call robotic, but I see where you're going. So one of the things, whenever Pete was talking about AI, we're working on deterioration indexes where we can, from the moment a patient enters the hospital, we know based off their demographic and their vital signs, how likely they are to have a decline within the hospital, and they can get extra monitoring. Our Overwatch EICU is also a process where we're looking into the patient's room and detecting deteriorations sometimes hours before they actually occur. So those things are ongoing real time in our system right now.
Any other questions? If not, Dr. Mundy, you're finished? So we will break until 4:10.
Nice job. Thank you.
Thank you.
Let's make our way back, please. I'll call the meeting to order. Dr. DiPaolo, I believe.
Sorry, I was getting one more barista there. Appreciate that, Chair Brockman. So what we're going to talk about right now and go over, and then obviously have a chance to get your input, is the third theme. And theme 3 is our distinctiveness as an academic health system. And I'll go to the first slide. This slide frames all of what we do under the university's strategic plan, the UK purpose. And you can see also in the upper right, and actually I can even show you here, the UK healthcare strategic plan. And we emphasized earlier that we haven't abandoned that plan. We're just going further, focusing in on 3 theme areas. And you've heard about 2 of them already, and I'm going to talk about the third now. We're going to continue to focus on quality and value and health equity as per the prior plan. But under the University of Kentucky strategic plan, you can see readily how we can leverage our academic strengths, especially our research and especially our education. And one of the prior meetings, we put up a triangle like this, or if it was 3D, a pyramid, I guess. And you got healthcare, research, and education. We're talking about 17 colleges, UK libraries, graduate school, many centers throughout, many initiatives. How do we leverage that? And I'll go to the next slide. When you think about distinctiveness as an academic health system, you think about what we have grounded in research, education, leading to new standards of care. When patients come here and standard of care is good, but could be better perhaps with cutting edge therapies and opportunities, we want to make sure we have those available for patients. It also brings up our level of expertise. When we're going into a clinic, a patient's going into a clinic, and you have research activity going on, clinical trials going on, that team that's involved in that discovery has a greater level of expertise to offer patients not only what's here today, but what's likely here and available tomorrow for those opportunities and cutting edge therapies. It also helps the community. It's an opportunity for us to give to the community opportunities where patients can come in if they need a clinical trial, for example, and then go back out to the community to be cared locally at home. The same thing in terms of our educational programs. It enhances what we do and our expertise overall. Obviously, it helps with the workforce for Kentucky, but it also enhances what we do. And then at the bottom here, at the bottom of the slide, are a few examples of things that we do bring to our community partners because of our academic strength as a university of Kentucky and for Kentucky. A great example is the Molecular Tumor Board, or precision medicine. So Markey actually has a system where multiple disciplines sit around a table, everything from the basic sciences that understand genomic science to various clinicians in pharmacy and medicine, nursing and so forth. And what we offer the community is physicians out in the community can send samples of patients' cancer to Markey, to us at the University of Kentucky. We will do genomic analysis, and that team, that transdisciplinary, we call it a transdisciplinary team, helps reason out the best possible therapy, very much individualized for that particular patient's cancer. If there's a clinical trial available with a new drug, a new opportunity, they're offered that opportunity. They can often be cared for at home with that advice. And they're even able to pipe in through video conferencing the physician or care provider of that particular patient to even be part of that meeting, to give them advice. So it actually, our research, getting into the community, and there are a number of other examples. I listed a couple more here in terms of the Stroke Network and what we do out of the Center for Health Equity Transformation under Dr. Nancy Schoenberg in terms of diabetes education, for an example, throughout the state. So we keep talking about this transdisciplinary approach in research, and we've been successful in the past in many different venues. And on the right here, it really shows the fact that a transdisciplinary approach is really signifying bringing everyone and all those disciplines to the table early in the process to try to solve a particular problem. Here, we're trying to solve the problems of these health disparities that we have throughout Kentucky, and we have multiple disparities. But we work in a team-like approach, especially on the healthcare areas. A few examples, especially in the research areas that have been successful with that type of approach, bringing multiple disciplines to the table, including what the Vice President for Research launched many years ago as our research priority areas, which help grow our research. I've had a lot of experience in the College of Medicine. We actually launched very analogous alliance teams. Again, multiple disciplines getting at the table together. A great example is the opioid epidemic and the HEAL grant, or Healing Communities study that was launched, the $87 million award that was awarded to Kentucky. That's a transdisciplinary approach. Around the table there, thinking about how to solve that problem includes disciplines, everything from psychology to behavioral science, to medicine, to nursing, to pharmacy, and so on. So one of the areas that we are planning, Eric and I with the team have come to a conclusion that we do very well in models like cancer, where we have everything under one umbrella, okay, within the cancer center. We have multiple disciplines on the clinical end. You have surgery, you have radiation, you have medical oncology, we have research incorporated, and we have that in these other areas. But what we're planning to launch in a staged approach is more signature areas where we get even more cohesive for all the different disciplines that fall under other key areas. And here's just some examples. Cancer, it makes sense in terms of the model. Cardiovascular, you could imagine all the different components on the surgery end, on the medicine end, bringing in the research. And we have those components going on, but going forward, bringing those together under one umbrella, under what we do at the University of Kentucky, and leveraging the strengths we have even across the campus. Neuroscience, pediatrics, you've heard some of that in terms of what we're doing in terms of enhancing advanced subspecialty care. Behavioral and mental health, women's health, transplant, and so on, obviously needing a staged approach on how we bring those together. And I'll give you an example of that. If you think about neuroscience or neurological disorders, you can imagine everything from Parkinson's to dementia to stroke and different disciplines dealing with all of those components. If you look at all the different areas that we have in units involved in neurological disorders, you can see a list of some of them here as examples. The Kentucky Neuroscience Institute, the Sanders Brown Center on Aging, the Department of Neuroscience, which is a very basic science department, the foundation of the research that drives to the clinical areas and gives us clinical impact. The Stroke Network, the Department of Neurology, the Department of Neurosurgery. When you bring together as a nexus research, education, and clinical care, there's more impact, there's more expertise. It helps us here, any patients that come in these doors, and as the example of the Molecular Tumor Board, can help the community as well. So I'm going to give you a very specific example, just one example, to kind of bring this home. And if you remember the triangle I showed you before, the top of the triangle was clinical care, to the bottom left was research, and to the bottom right was education. So imagine that triangle overlaid on this particular slide. This is a lot of the work led by a key leader, Justin Frazier, Department of Neurosurgery, a neurosurgeon, who has a large team. It says research team, but it's research and clinical. And you can see there neurosurgery, neurology, radiology, neuroscience, nursing, IT, engineering, pharmacology, just to name a few, sitting down together on a regular basis, sorting out how they can synergize and have greater impact, how you can bring the research to the clinic, how we create new clinical trials. And what's shown at the top is the process, we call it endovascular thrombectomy. There was a recent New York Times article about it. About a month ago, there were 2 New England Journal articles in terms of studies of the benefit of when patients come in to the emergency department with a large vessel stroke, and this is a thrombus blocking off one of those vessels, some of the brain tissue starts to die. You want to stop that as soon as possible. You want to get that thrombus out of there. This is a very interventional approach. It is advanced medicine, where a catheter is put into that vessel, they snare the thrombus and pull it out. Well, Dr. Frazier and his full team have done research, and this is depicted here. These are neurons on a petri dish, you could imagine. And he's shown, or they've shown, that if you give a certain drug and you've starved these neurons, by the way, we have almost about 100 billion neurons in any of our brains. I don't know if I have as many today as I did when I started a few months ago. But we have 100 billion neurons. And if you can imagine, in this one here, they gave the drug verapamil, and then they starved it, and they also deprived it of sugar, of glucose, just like what would happen to our brain if you cut off the blood supply. And here's one where there's no drug. And I don't know if you can tell, but it has less branching. This has a lot more branching, a healthier neuron. Imagine multiplying that by many. And so by that science, they brought it into a clinical trial, and we offer patients here the opportunity to not only have the thrombus removed, but while the catheter is in there, to inject some of that drug that might be nerve sparing, so for brain recovery. The early results look good. It is a clinical trial, but it's an opportunity for patients to participate and get something that's more cutting edge in terms of an opportunity in brain recovery. And that's not all. I said that there was research in the bottom left. I said there was clinical care in terms of actually advanced care. This led to clinical trials and opportunities. And to the bottom right, an incredible educational approach. They have set up a system to connect with, I think it's now 25 different hospitals around the state. So not only if a patient with a large vessel stroke comes into our emergency department, if they come in any one of those 25 hospitals, and we can expand it, and I know they're trying to expand it as well, we can actually assess, review their scans, and help guide them to a proper care decision. And it could be that they can care for them right there on site. Or it could be, hey, transfer them in because this is somebody that would need an intervention. So it's an educational process, but even more than that, it's taking a lot of the research activity and bringing it to the community as well. So a couple of other examples, and I'm not going to go through them, but just to say that's only one example. So I've given two in a way: the molecular tumor board, part of the stroke network, the example I just gave, but there are many more, and these are just a list of a few in terms of what we do and our strength as an academic health system to help the community, to help obviously patients that come in our doors, but help with education and also access for that advanced care, for that academic care. And then how do we enhance that? So Eric and I have met with the teams. We've met with much of the College of Medicine leadership as well, and the leadership of the other 7 total healthcare-related colleges, as well as some of the colleges throughout the campus. And we have biology and chemistry going in arts and sciences, one of our more undergraduate programs or colleges that set up most of our undergraduate programs. Having those collaborations will enhance the ability to do much more of that under these signature areas. But we're going to need to improve the infrastructure to take the laboratory research and bring it into the clinic. When I was in the College of Medicine, we helped grow under Dr. Cassis's priority areas, many different areas of research, a lot of it basic science, some of it clinical research. We now have the foundation of research as a base to bring more of it into the clinic on a more rapid trajectory. To do that, we need to look at, and we're looking at it now, the various areas where we support clinical research. And I've listed some here, obviously under the Vice President for Research, but we also have what's called the CRSO, the Clinical Research Support Office, that helps with the clinical research regulatory parts of things and oversight. We have the Center for Clinical and Translational Science. We have various centers that have some infrastructure, and we have infrastructure in colleges and in departments. If we look at that in a more consolidated, cohesive way, we have an opportunity to strengthen that, like we do with other particular areas where we give oversight and bring things together. More of a resource for these clinical investigators. So investigators like a Justin Frazier are able to get these discoveries into the clinic sooner, make them available for patients. And then the last thing I want to talk about is education. Education is critical from a number of different perspectives. We always think of it as increasing the number of learners that'll go out into the workforce. And when we're talking about the healthcare workforce, it is needed, whether it's physicians or health sciences or nursing, and we're working on that. But we also have learners throughout our whole system, and they're there to learn, but they also support lots of the care we do. So the ACGME, or Accreditation Council for Graduate Medical Education, we have over 800 residents and fellows throughout our system. And many of them are out in various community hospitals as well, doing rotations and so forth. So they're helping as well, and they're also bringing some of the more advanced care and opportunities to those institutions as well. And then in terms of a pipeline, you've heard about the health education building. This is going to be incredible, and from a number of perspectives. One is it's going to allow growth, increase capacity, so we'll be able to have more seats in terms of physicians. So College of Medicine, with the expansion of the 2 campuses, went from about 550 students total to 800 students. With the health education building, it'll go to 1,000. With the health education building, nursing, as I think Trustee Kramer mentioned before, and it was mentioned earlier, is that there's a plan, although we've got to do it with the proper business planning and so forth, to double the numbers of graduates in nursing between now and the year 2029 under Dr. Manus, the new dean in nursing as well. And then I just wanted to make the last point as well. You heard we just got through our SACS reaffirmation. I'll give you an update on that tomorrow. But one of the plans that came out of that is the Quality Enhancement Plan, which is the same concept, bringing multiple disciplines to the table, but from an educational perspective, so students have a greater understanding in how to bring disciplines to the table and how that has more impact in solving problems. And each of those settings where students will have an opportunity at the table, it'll be focused on a particular problem. You can imagine a transdisciplinary group working on the opioid crisis, and you could imagine the disciplines I mentioned earlier sitting around the table. It may also guide a student's decision-making in terms of their educational program based on their passion and what they want to solve in terms of helping Kentucky. So I'll stop there and just hit these couple of conclusions and open it up for questions. Essentially, we're talking about transdisciplinary research, transdisciplinary education and service to care for the needs of Kentucky. More importantly, we're leveraging just an incredible opportunity here when you look at us as a comprehensive campus with everything in terms of, the research to education. As I mentioned earlier, 17 colleges, a grad school and libraries, multiple centers throughout, and these more integrated approaches are having high yield. Through the signature areas on the clinical and research end, we will have a greater opportunity to be more cohesive. It also helps with coordination of care. So a surgery is done in a particular discipline, like in a cardiac surgery, and then somebody's followed up by a cardiologist. Again, multiple disciplines and coordination of care. This is our distinctive mission, and certainly our research is focused on Kentucky's needs. If you think about those focused areas, whether it was the alliance teams or whether it's the research priority areas, they're all about focusing on the health disparities of Kentucky. And with that, I'll stop and turn it back over to Chair Brockman.
Floor is open for questions. Dr. Swanson, you're always good for a question.
Thank you. Provost Apollo, when you think about all the challenges that we have in expanding clinical research, what do you think is our #1 challenge in moving clinical research forward?
Well, I think that in some institutions, the challenge is you don't have enough discovery and enough basic research and science going on. We don't have that problem. We have tons of it, and the growth is amazing. I mentioned earlier, 450 million in terms of awards every year. We have more basic science than we have clinical science. The majority of the bottlenecks in terms of getting more into the clinic, more clinical trials, includes one, infrastructure support. We want to be able to, I mean, the clinicians, even if they have a foot in research, they need to be part of a team. They need help, and they're busy. They're very busy. So having an opportunity for them to have more of a seamless approach where when they have a great idea, they're basing it off of research by their team partner who might be more on the basic sciences. They have the resources. We have those resources, and they're in multiple different areas. They're in multiple different departments, even multiple colleges. Having it in a more cohesive way, and that's the opportunity going forward, I think that's going to be important. The other thing is recruitment and mentorship. It's not easy to actually do all three as a clinician, okay? I'm getting old now, okay? Back in the day, so I think I was always called a triple threat. You don't see that as much anymore. You need a team approach. You need somebody who's totally based in research, somebody who's mainly in the clinic, and they're working together as a team. And so we need to recruit properly as well and incentivize that to be sure that they're going to be able to be successful. So I would say the two key areas is proper recruitment and mentorship, and the other is enhancing what we already have in terms of infrastructure support to make it a little more seamless for those that have creative ideas. For people like Justin Frazier, I mean, Justin Frazier's a busy clinic. He's in the OR. Actually, to be honest, he was going to be here today, but he's in the OR today doing probably what we've just been talking about.
Any other questions? Dr. Paulo, thank you, sir.
Thank you. I'm going to ask Dr. Monday to continue on the more quantitative end of what we're presenting today.
Thank you, Bob. So we have concluded, or we are concluding the qualitative discussion. So what has been represented thus far, the three themes, walking through those, we'll summarize those once again just in a moment. So now transitioning to, while we did a qualitative refresh, we also did a quantitative refresh. So taking fresh eyes to our financial plan, when we think about just UK healthcare, and I'll walk you through some assumptions, and then Senior Vice President, CFO Craig Collins is going to join me up here in a moment and walk you through some actual numbers and data. So how we do financial planning at the institution is the plan is based on best available information, right? So it's something to hang our hat on. There's some resource or reference that we have to find. One of those could be, what have we achieved over the last 5 years, 10 years, 15 years? What is the market saying? What's foreshadowing in our future? What is Vizient saying or other data sources? So when we take fresh eyes, or when we took fresh eyes to this, we built it up from the ground up. So start afresh, build it up the ground up, and later we're going to be asking for an endorsement of this 5-year financial plan, and we're locking it down. So we will then show you change and actual results according to this plan. So it'll evolve, it'll roll as every financial plan, but we want to lock this down so we can always go back to a reference point. That is different, it's more defined, and that's on purpose because what we're asking for, of course, is a lot of design, not as much construction. Of course, the construction costs are multiples of the design costs. So how do we prove, how do we earn our way to fund the design? That's funded in what you're going to see. The construction is not. So we have to achieve that financial plan that then opens those doors to do the construction in the coming years. So here are the assumptions. This is a 5-year financial forecast, quantitative forecast. All right, number one, we build baseline projections of volume bottom up. So this isn't built by the C-suite. This is built with working with our clinical chairs, their administrative leaders, and back and forth. What they think the volume is going to be based on data, utilizing all of our experts and expertise, but it is a bottom-up build, and we have done that in UK healthcare for decades. And so that is a best practice. You do not see that in all organizations. Number two is when we think about revenue assumptions, we have to think about COVID as a component of time, right? We're going to regress to the mean. We're going to go to things that we do not benefit as much during COVID. When we think about patient mix, when you think about payers, when we think about bad debt, it is reverting back to, or it's coming to, let's call it a post-COVID environment, which is more aligned. to some of the situations we saw pre-COVID. Number 3, directed payments. We've had a long conversation about that already. It is the most significant financial risk we have in our enterprise. No doubt about it. It's pretty much 20%, folks. About a $3.4 billion book. If you're thinking about 650 million, let's just call that 20%. Now, we heard from Jason that said there would always be something, right? There would be a supplemental payment. So even if it was at 330 or 350, we're still talking about several $100 million. And that's one of the reasons why we're talking about design and not just construction. And so, but that is a risk. It's one that we mitigate, we manage, we transfer. You're never going to extinguish it, but we work to manage and mitigate that. Number 4 is bad debt. Referenced that already. It's going to come back to pre-COVID levels. What does that mean? It's a large number, right? During COVID, it got a lot smaller because we could assume everyone, for example, qualified for Medicaid. Well, that changes. And we can talk about that, of course, in more detail. Next bullet, very important. Best available information. And this is informed by what we've seen the last 5 or 10, but it's more informed about what the market is telling us. What we've been able to do in labor the last 5 years, we're not going to be able to do the next 5, folks, right? It's going to cost us more. The labor market has never been as tight in modern times as it is right now. And I'm not sure I've found anyone that says it's over yet. So how do we think about that? How do we think about bennies? How do we think about supplies, pharmaceuticals? And so they're tied to Vizient or World at Work or the local marketplace. And it's tied to something we're hanging our hat on. We're not guessing here. Is our plan going to be perfect and 100% correct? Of course not. But it's going to be based on best available information. Last bullet. Every time in every organization, whether we look at our personal budget or we think about the budget of the University of Kentucky at almost $7 billion on July 1st, or healthcare that's $3.4 billion this year. We can do one of two things. We can augment our income or we can reduce our expense. Well, we do both, right? And so we're looking at ways in which we have performance improvement goals that how we build this budget. That is the ownership of that leadership team. So if you want to think about that C-suite, that is what we're talking about, what we're resourcing, what we're working with the team to think about every day. And so workforce, yes, we have to reduce our number of travelers. That's a 2.5x, folks. We're paid 2.5x more for a traveler versus a non-traveler nurse. So we have to adjust that. When we think about revenue optimization, that's how we code. That's working with our clinical leaders. That's looking at strategies and consultants that can help us maximize our reimbursements for the actual services we're delivering. Operational efficiencies, this is institution-wide, enterprise-wide. How do we think about how we do business? Have we grown too much in this area? Have we not grown enough to take advantage of another opportunity? And then when we talk about BD, or business development, we're not going to be doing business development for the sake of doing business development. It's a burden and a cost, right? So how do we think about margin related to outcomes? Jason gave that great chart. You know, when we talk about it, Rob talks about it. Rob and his team are thinking about this every single day. Are we going to buy it? We're going to build it, or we're going to partner. So strategy, talent, infrastructure. How do we achieve talent infrastructure? We can buy it, we can build it, or we can partner to achieve it. So that's the concept, that's the flow, that's what we did. And now let's look at the actual numbers. Craig?
All right, thank you, Eric. And it's a pleasure to be in front of the board again today. And so I get a chance to talk to you a little bit about all the fine work that's been done by many of the folks out here in the audience. But the first thing, as Eric said, is that we start with the volumes. And here are the volumes that were used and projected. This table presents the key volumes for the forecast. Two of the most important volumes that are here are our inpatient discharges and our medical practice group clinical services. So when you look at those two line items, this is the, whoops, that went off on me. This is really where we're starting to project where our revenues and where our expenses are going to grow and be profitable to the organization. The total discharges are projected to grow approximately 16% over the 5-year period, and the medical practice group's clinical services are to grow about 26% during that same time period. So that's the assumptions that the base of this budget or this 5-year forecast is built upon for us as we move forward. I know this is a little bit of an eye chart, but the current projections support the proposed $1.8 billion of capital spending that you've heard about thus far today, and you'll see more FCRs on. The pro forma outlines UK Healthcare's projected financial results, and it includes those performance improvements that Dr. Mundy just outlined in his previous discussion. I want to draw your attention to the middle of the slide and the profitability. Again, I am not doing well in pressing buttons. This is the area that I'd like you to look at. So when you look and see where we're at against the rating agencies, Moody's and S&P, in operating margin, they're in a range of 3.6% to about 4.7%. If you look out all 5 years or 6 years of this projection, we are over that goal or that benchmark that's set by the rating agencies that look at healthcare organizations. Our operating EBITDA margin is, the range is 9.3 to 11.2%. Again, in all years of this projection, we are in the pocket or above the operating EBITDA margins that are projected by S&P and Moody's. When you get to the end of the 6 years, we grow our operating revenue to about $4.2 billion. So continuous growth in the operations of this organization. And the other area that I'd point out that's very important to us is that within the days cash on hand, yes, we're below what Moody's or S&P would project, but we're using about 150 days as our projection. We stay above 170 every year in the next 6 years and are still able to invest into this organization without any debt. So this is a simple chart. It's really taking us forward and reflects UK Healthcare's sources and uses of our cash in support of the plan that you've heard about today and the way that we've built our operating budget for the next 5 years or our forecast. Our uses of capital includes that $1.8 billion worth of investment that you've heard about today, and it also includes our debt payments. It also fulfills what our minimum cash position needs to be during this time period. So for total uses of cash, it's about $3.8 billion during this time period. The sources of cash include our current cash balance of about $1.2 billion, along with the projected future cash flows that are produced by that plan that you saw in the previous slide. That totals to about $4.2 billion. This provides then a surplus of about $645 million at the end of the 5 years. So we have $645 million that we can use to invest in other activities, maybe our staff, maybe in other functions of the organization as we move forward. So as Dr. Mundy pointed out, our plan is to lock down this forecast and use it as a base measurement for our future. As we progress and achieve this forecast, our leadership will assess the timing and the resources that are needed to implement the design and the planning of our future operations around the Chandler Hospital and around the Hamburg campuses. And we'll come back to you with those updates as they continue to progress. Let's talk about where we're at right now so that we can set the stage and show our results current year-to-date through March 31st of 2023. Year-to-date, our March totaling operating revenue exceeded our budget by $86 million with a total operating revenue of $2.6 billion. Right there. And there's our positive variance to budget. Year-to-date, our operating expenses exceeded budget by $49 million, with the majority of this variance in variable expenses. And this is driven primarily by our retail and specialty pharmacy drug expenses, which are offset by the corresponding increases in our net outpatient service revenue. So there's the negative variance, and we gain some of it back through our billing process in outpatient services. Net non-operating revenue has a positive variance of 48 million, and it's due to a greater than budgeted investment income, resulting in a year-to-date net income of $333 million against a plan of 249 million, so a positive variance at this point in time of about $85 million year-to-date. Lastly, at the last board meeting, we gave you a preview of what the incorporation of Royal Blue Health, or King's Daughters, was within our operating results. And this is reflected year-to-date, combining both organizations into one income statement. King's Daughters operations added an additional $347 million of total operating revenue to our income statement. It also had $294 million of expense, which provided bottom line wise a net impact or increase to our total operations as a healthcare enterprise of $83 million of income. Now, granted, this is only December through March for King's Daughters in incorporation to our overall income. Our combined net income is $416 million, a positive variance of $129 million for the healthcare enterprise. I'll pause at this point and ask if there are any questions around the financial numbers or the presentation.
Are there any questions? I actually will throw out one. I'm probably the least qualified to be talking about debt ratios, but is there any prudence to actually having some debt on the books? Looking at Bed Bath & Beyond and their stock buybacks, and they became cash poor and now they're bankrupt. So just a question.
Yeah, I think, we've got to step back and look at our total overall university book of business to understand where we want to be within that debt ratio. And at this point in time, we're able to accomplish all of this with cash. And if you think of where the market's at this point, it's most prudent, I believe, at this point to pay for things through cash. But in the out years, you'll see we continue to pay off our debt. And that will be when we have an opportunity to really look at whether we want to issue new debt towards the construction of some of these new projects. Eric, I'd ask if you have any other comments.
Asked and answered. Thank you. Any other questions? Dr. Swanson.
I have a similar question. On your slide with the projection, and we're looking at liquidity. And so in 2023, it's 289%, and then in 2028, it's 723. So it's about double. Could you explain what that means?
As you continue to see, we continue to have additional days cash on hand that helps to pay into and be a part of that ratio that is calculated. So it is all part of what takes place as we manage our activities across the organization. And it's our cash to debt, and our debt continues to be reduced. We're paying off debt and we're not issuing any new debt at this point in time.
It's a direct result of the $222 million of debt is paid off. If you look at the ratio, we have total debt in 23 and healthcare 522. That goes down to 300 million in 2028. So lower debt, more cash, just a direct ratio.
Mr. Profit.
Yeah, in the volume forecast section, really like the growth in the medical practice group clinic over time, trying to understand the spike in ED visits this year and it going back down to what could be back to normal next year.
So I think a lot of this is only looking at the outpatient component of ED visits. So these are patients that never become an inpatient to our organization. So the volume and overall emergency room visits have continued to grow year over year and are projected when you put both components together. So it's really that mix of what comes through and might present and does not need to be admitted. We're seeing some reduction in that activity in the forecast right now.
Trustee Gosney.
Simple question about travelers. You mentioned they were, and I know it's challenging to manage them. You mentioned it was 2.5 times a regular employee, but is that comparing, obviously you're not paying benefits to them. So is that even without benefits, it's 2.5 times?
Yes, that's just straight rate.
Straight rates, okay.
Any other questions?
I have one.
Yes,
Mr. Chairman. We spent quite a bit of time talking about directed payments, and as someone on this board and been on this board for a while and on this committee, I'd feel a lot better hearing about directed payments from maybe the expert on directed payments in the country, Dr. Birdwhistle. Do you feel that we're in a pretty stable position nationally? I know it's a forecast, but I'd feel better hearing from you.
Don't you all leave me. Thank you, Dr. Melanson. Fortunately, I've been over here writing scripts because I knew it was going to come from someone. I wasn't expecting it to come from you. So we have had supplemental payments since 1994. When I joined the university in 1994, we had supplemental payments at that point, and they have continued. The reason we get the directed payments, it's because of the complex patients we serve. It's because of the socioeconomic factors of the patients and the regions from where they come. That's what these payments are all about. Jay was helping me with our case mix index. Was it 2.4? That's at this one. 2.4. A community hospital, 1.7, 1.9. So these payments are designed to make sure we are here to take care of the patients who depend on us. So there was a change in these payments in 2016. They worked like a block grant. They just got a lump sum of money, divided it by 12, and everybody was happy. The feds changed the rules. Part of the rules were, it was based on actual numbers of encounters. You see the patient, you get the money. You don't see the patient, you don't get the money. They flexed up the amount of the payment in order to entice systems such as us to focus on quality. If you'll recall, we've talked about this, 20% of that amount of money is put at risk, assuming we meet certain quality metrics. It has transformed UK healthcare. We are a quality-driven organization. That is what the intent of the policymakers in making this change was. They were willing to up the game, but they wanted to see that they were getting a bang for their buck. They were actually seeing patient visits. They wanted to drive up access, and they wanted to drive up quality. So the question earlier is, are these payments here to stay? Yes. Will they change? Yes. As healthcare changes, there will be recalibrations, but these at their core are designed to ensure that we can be here to serve the patients that depend on us for their care. Is that it?
Further questions? Seeing none, thank you, Mr. Collins. Dr. Monday.
So Bob and I wanted to pull this slide back up, and then the next component is a look at these finance committee resolutions. But just to summarize the takeaways on the qualitative one last time. So to set the deck, we worked with our teams to understand and take fresh eyes in addition to, not in lieu of. Our commitment to quality, which is absolutely amazing, and what we've seen in increases and growth in that, is still in front of us to achieve even more. When we think about serving our community, and number two, and how we think about our employees and taking care of the base, as well as moving ambulatory out. Theme number 3 that Bob went over in great detail of how we utilize and the differentiator of having an academic health system. So these are the summary, these are the conclusions of the qualitative discussion. As it relates to the quantitative, we have prepared a 5-year financial plan that we believe is based on best available information. It is reasonable, it is achievable, and based on what we've been able to achieve in UK healthcare over the last number of years, we believe that will be achieved in the future. Keep in mind, point in fact, let's use actual rather than budget. This year, we had targeted a net bottom line of $352 million. Through 9 months of the fiscal year, we're at $333 million. Now, we can lose money in months too, not just make money in months, so there's still 3 months in front of us. But we feel very confident in our ability to achieve the actual results in fiscal year 23. That, of course, is a predictor of what we see in the future. But the days are many and the challenges are mighty. But at the same time, we believe this is a reasoned conclusion, Mr. Chairman, and a reasoned plan. We are prepared to take any more questions, Mr. Chairman, or move into the FCRs as you deem appropriate, sir.
Any questions for Dr. Mundy? Seeing none, we'll move forward to FCRs. And let me add that we are going through several FCRs or Finance Committee reports. We are either sending them to the Finance Committee with favor or without favor. The Finance Committee will then meet tomorrow and will send to the full board either for approval or not. So with that said, FCR 12.
Thank you, Mr. Chairman, members of the Healthcare Committee. FCR 12. That is an FCR to improve UK healthcare facilities. You heard about these needs in theme 1. You heard from Dr. Conwell, Dr. Day, Dr. Roan. You did not hear from Dr. Humphreys, but that is referenced here as well when we think about the ED projects. This would allow us to expend up to $82 million on these 4 projects. What would it do? 34,000 square feet of space in Pavilion HA. This is the OB project that we've been talking about, labor and delivery, for, I think, over a decade. And so this theme of let's stop talking about it, let's start implementing. Number 2, we heard from Dr. Conwell talking about the endoscopy and the endoscopy need and building out this advanced endoscopy space. I hope you see in 2, 3, and 4 this theme of implementation to finish Pavilion A. So that's one of the places we can. Number 3 is an observation unit adjacent to the ED department. About 5,500 would give us additional observation space. This is a positive of COVID. We always talk about the challenges. Well, we stretched ourselves in COVID to determine it was called the Costco space. And this is now something we can make permanent, attached to the ED. And then number 4 is to finish off the ORs that are sitting ready to be finished off in Pavilion A. When you think about a pavilion and you think about the time when we started planning that, till we opened it, to when we're actually going to finish it, you know, we're talking about as many as 20 years. We're just going to finish the final floor, patient floor, in January, and then these projects will take, some of them, another few years. So that is FCR 12. Mr. Chairman, stand for questions.
Do I hear a motion, first of all, for approval of FCR 12? Trustee Melanson, second on that motion. Dr. Swanson, the floor is open for discussion. Seeing none, all in favor of FCR 12 signify by saying aye. Opposed, no. It passes. FCR 13.
FCR 13, Mr. Chair, members of the Healthcare Committee, this is a project where we're seeking approval to expend up to $30 million to design a medical office building at Hamburg. This project would be focused on the design phase only, would be a first phase of a multi-use of the Hamburg property and land, and it is well within our legislative authorization of $250 million. And these are $30 million of agency funds, which are cash. Mr. Chairman.
Do I hear a motion for approval of FCR 13? Trustee Daniels, second on that motion. Trustee Gohagan, the floor is open for discussion of FCR 13. Seeing none, all in favor signify by saying aye. Opposed, no. Passes. FCR 14.
FCR 14 is the evidence, the best evidence of the outcome of the challenge that we heard in our qualitative refresh. That is a seeking permission to spend up to $180 million of cash to plan an expansion of Chandler in the Chandler facility. We don't know the exact size or exactly the location. That's what we would do within this design phase. We have shared a great deal of data to show the need, and specifically how we need to be able to be in a position to say yes to those 5,000 transfers rather than maybe or no. Mr. Chairman.
Do I hear a motion for approval of FCR 14? Trustee Melanson, second by Trustee Gohagan. Floor is open for discussion. Seeing none, all in favor of FCR 14 signify by saying aye.
Aye.
Opposed, no. Passes. FCR 15.
FCR 15 is a more transactional FCR, and the next two will be similar. These would be normally what we would see in a healthcare or a finance committee. But specifically, they are important as well. This is to approve the lease amendment for our specialty pharmacy services. We've talked a good bit about specialty pharmacy. This need has grown as we went through and as we have exited COVID. And so this would allow us to lease about 30,000 square feet, a little bit more, at a pretty good lease rate of about $37 from last time to $38.62 this time, more of an inflationary increase. Any lease greater than $200,000 annually comes in front of the board for consideration. FCR 15, Mr. Chairman.
Motion for approval of FCR 15. Dr. Swanson, seconded by Trustee Gohagan. The floor is open for discussion. Seeing none, all in favor of FCR 15 signify by saying aye.
Aye.
Opposed, no. It passes. FCR 16.
FCR 16 is also approval of the lease. The board authorized the EVPFA to negotiate and execute a lease for office space for UK Healthcare, more administrative staff. This lease would be with KMSF. This is an extension. The current lease is up. This would be an extension thereof. The terms and conditions of that extension are materially similar to the previous lease, with one exception. The common area maintenance fee will go from $10 per square foot to $11 per square foot. The base lease rate would remain unchanged at $16.10 per square foot. Mr. Chairman, FCR 16.
Do I hear a motion for approval? Trustee Daniels, second by Trustee Melanson. The floor is open for discussion. Seeing no discussion, all in favor say aye.
Aye.
Opposed, no. Passes. FCR 17. Dr. Mundy.
Mr. Chairman, members of the Healthcare Committee, this is the board. We are requesting you to confirm the President's approval of the initiation of an emergency replacement of air handling unit coils capital project. This is a $4.5 million project to be funded with insurance reimbursements. We had a significant event in December in Lexington, specifically on our campus. We lost 31 air handlers or air handler units on that evening and into that morning across the enterprise. Some of those are within our healthcare facilities for Chandler, Good Sam 2, and so on. So this would replace the broken coils as well as to replace them with freeze-proof coils so we're not in this situation again. $4.5 million project, insurance reimbursement proceeds, FCR 17, Mr. Chairman.
Swanson, second by Trustee Gohagan. The floor is open for discussion. Seeing none, all in favor say aye.
Aye.
Opposed, no. It passes. Thank you, Dr. Mundy, if you're finished.
Yes, sir.
Before you now is a resolution for your consideration, UHCCR1. In the most straightforward of terms, we are asking for your approval of the strategic goals you heard about in detail today and the 5-year financial plan necessary to turn those goals into reality. Dr. Mundy just summarized the major takeaways from the day. the themes that define what we have been throughout our history, who we are today, and what we must be tomorrow if we are to do our part as an academic health system to advance Kentucky. Our mission has not changed, but we are reframing and recalibrating how we will accomplish that mission to meet Kentucky's health needs. The goals we have and the plans we are making are audacious, but they are achievable, and I would submit that they are essential. For our state, there is only one UK Healthcare, the place where people turn to receive the most advanced care for the most acute and complex needs. But continuing to honor that responsibility means building more capacity on this campus to heal more people. No one should have to leave Kentucky to receive the best of care, and no one should be turned away either. For our people, there is only one UK Healthcare to provide the most advanced care and to meet their basic health needs too. But meeting their needs means extending more care to where they are through ambulatory sites that provide outpatient and specialty services closer to their homes. It also means recruiting and retaining the talent that advanced care and outreach requires through competitive compensation and partnerships that build out pipelines. And it means paying particular attention and investing resources, space, and talent toward meeting the health needs of those who live in medically underserved neighborhoods in our community. What zip code you live in should not dictate the kind of care you receive. It's our calling to make sure that it does not. And for our future, there's only one UK Healthcare. What makes us distinctive is the capacity and commitment we have and the responsibility that we bear to bring more healing and hope to our state as an academic medical system within a growing and thriving university enterprise. Our campus, one of only 8 in the country with the array of disciplines and a growing academic medical system on one campus, makes us special. It gives us the potential to do so much more for those we serve. To that end, the 5-year financial plan details the resources necessary to sustain and grow what we do and how we distinctively do it. The resources we generate through our efforts will enable us to do even more to advance the health of our state, to advance Kentucky. It's what we have to ensure that we are marking our progress as metrics become milestones. We have re-examined our vision and the mission we alone are capable of to help make a healthier Kentucky possible. That mission, still compelling and more relevant than ever, remains fixed. What we are resolving today is to reframe and recast it to meet the health needs of our people during a time of dramatic change, continued challenge, and tantalizing opportunity. I'm excited about what is possible for our institution and for the health of the people we serve. I would now entertain a motion to adopt UHCCR 1, Advancing Kentucky, Growing as an Academic Health System Within a University Enterprise. Do I hear a motion?
So moved.
Trustee Daniels and
So moved.
seconded by Trustee Gohagan. Any discussion on UHCCR 1? Seeing none, all in favor signify by saying aye. Opposed, no. It passes. I yield the floor to Physician Executive Dr. Jay Grider to present the list of privileges and appointments. Dr. Grider.
Chair Brockman, the committee has before it the list of physicians, APPs, and clinicians who've undergone the credentialing and privileging process to be included in the active medical staff at the University of Kentucky. I submit them for your approval.
Dr. Grider has submitted the list of privileges and appointments. Do I hear a motion for approval? Trustee Melanson, seconded by Dr. Swanson. Floor is open for discussion. Seeing no discussion, all in favor signify by saying aye.
Aye.
Opposed, no. It passes. Thank you, Dr. Greider. Moving on, is there any new business to come before the University Healthcare Committee? Seeing none, the meeting. I'm sorry. You count too, Mr. President. You can.
I would be remiss if I did not extend my deep appreciation for all of the people who made possible what you heard today. When I asked Eric Monday and Bob DiPaolo to step in as acting, I meant for them to act, and you can see that they did. And I also, when I met with the chairs and the operational leadership that you've heard from today, I said in reality, in terms of UK healthcare, they were going to be the board of directors in terms of shaping a plan that would help us meet the needs of our fellow Kentuckians. So I want to thank all of them. You can't imagine the countless hours of work that they have invested, but what I appreciate is the selfless, collaborative focus. And then I thank all of you, our board members, for your careful attention and your good questions today. This, to me, is what informed decision-making should ideally reveal, and it, I believe, is well reflected in your questions and in the presentations today. I cannot remember the quote. I was trying to Google it. I think it was made by a French general when he was in his garden and he was remarking about how beautiful the blooms were on a particular plant or tree. And he asked his gardener about it. He said, well, you know, if you plant it, it takes 200 years to bloom. Obviously, the general was not going to see the bloom, but he looked at his gardener and said, plant it this afternoon. So our fellow Kentuckians cannot wait another day. They cannot be turned away another time. So I go back to my gratitude to everyone. The work that has been compressed into these last few months and culminating in your support, unanimous, I would observe, of these FCRs, I think is one of, well, it stands as an historic board meeting in terms of my 12 years at Kentucky, so I thank you all.
Thank you, Mr. President. Any other new business? Seeing none, the meeting is adjourned.